We had a plastic surgeon standby who was I was lucky enough to get him. And what he recommended that there was a small tear, so you can directly repair the pleura. So we repaired the pleura and then checked it with Valsalva maneuver by putting a saline in that dip. And fortunately, there was no leak, so we continued with the surgery and we closed the wound. To my surprise, that was not the end of the events. I turned the child supine, I found that she doesn't have any movement in the right operated upper limb, and there are no palpable pulsations. Even pulse oximeter, there was a decreased saturation compared to opposite side. The capillary refill was normal. So I did re-exposed clavicle and did a second osteotomy. Even after that, there was no return of the pulse. There was marginal improvement. So I did a morselization as Samir had already advised. And once I did the morselization, I got the pulsation back and there was complete resolution of neurological thing also. So she did not have nerve palsy, and this is how it all went. First, I did two-level osteotomy. It did not improve, so I morselized and then closed. And this is her immediate post-operative X-ray. Any comments, Samir? Should I have anticipated this and done earlier? I think Sandeep has a paper in which he has done a couple of morselization. And there are a few authors who routinely do morselization. And there are a few authors who do not do any clavicle procedure. So what are your views, Samir?
Usually in an older child, I would do clavicle morselization, or if it is really very high riding.
So could you define the old age, because it may be very relative?
Pardon?
What would be old age?
Old age means more than 5 years.
More than 5 years. Abhay, any different take?
So actually, we don't do any clavicular procedure, and we published the series recently. The difference that we would do along with the woodward is we would also excise the superior part, superior aspect of the clavicle, like green, a modified green, and so that gives the cosmetic appearance. And we tend not to pull the clavicle down too much. Releasing the adhesions under the scapula, like you had done, usually improves the varus positioning of the scapula and helps with improving range of movement. But we've not done a clavicular morselization, and fingers crossed we've been lucky with it.
So I completely agree. In my paper, I've reviewed a lot of literature and found that clavicle osteotomy has no consensus. There are a lot of surgeons who just do not do it. There are people like me who have midway path, just break clavicle at one place. And there are people who completely excise middle third segment of clavicle, as well as there are people who do morselization. So there is not end of story. This was 2 months follow-up. She had significant improvement in cosmesis as well as abduction. This is her 4-year follow-up showing almost normal scapula and excellent abduction. But and there is a good cosmetic results. There you can call this as a slight winging, but I've observed that because of the hypoplasia of the muscles, even pre-operatively, this type of picture is there. Since I started documenting all the cases pre-operatively, I find more than 80% of the cases of scapula have a prominent scapula on the involved side. But to my surprise, this girl at 4 years down the line, she developed clavicle non-union. She was absolutely asymptomatic. And when I asked parents that they should go for a surgery, they are not willing to go for surgery. So Abhay, do you think there is anything special for this complication, because this is not reported in the literature till date?
Well, so she's had an excellent cosmetic result and functional result. If the family is not keen to intervene, I would leave it at that. I think this is more a radiological worry than a clinical issue. So I would just leave it alone.
So Rujuta, there is a statement, there is a very important fact that the congenital pseudoarthrosis of clavicle always happens on the right, and this happened on the right. So do you think there is any connection, or this is just my bad luck?
So we have seen a lot of clavicle non-unions following plexus explorations, and the longer we have been following them up, we have seen that largely they are asymptomatic. Similarly, they occur mostly on the right. I think these are just associations which happen in any complicated upper limb surgery, especially where you have the periosteum probably, which is very hypoplastic to begin with as well. And probably when we are giving it a lot of traction and morselizing it, you don't realize how much you're nibbling off. So that could be one of the reasons that this happens. Of course, in plexus, we think that it's probably due to the fibrin glue, which kind of tends to seep into the cracks and kind of acts like an interposition and prevents it from not uniting. But it's a known association to have it on the right. If you have it very, very severe and if it's really causing a problem with the version, then at times we have attempted to reconstruct that clavicle with a non-vascular fibula. But by and large, they are asymptomatic and it's very tough to convince the parents to go ahead for any surgical procedure for that.
So I think just to sum up, this is a rare condition, but the commonest condition with shoulder. Multiple associated syndromes could be there. Klippel-Feil is one of the bad ones, which you should be careful. And when you are doing this, you should be careful about brachial plexus and sometimes very, very rare complications like pleural injury and vascular complication. Abhay, now we move on to your case. Please take over.
So good morning. I'll be taking us through this next case. We had to do a last-minute quick substitution overnight because what we originally planned was discussed in great depth yesterday. And thanks to Dr. Premal's excellent documentation, we've got a nice case that we can now discuss. This is courtesy Dr. Premal. That's the next slide, please. This is a 10-year-old girl who was born with history of left elbow deformity and restriction of movement. She did have some pain on and off. And she gives history of an infection at 5 months of age, for which an IND was done. She was seen by an orthopedic surgeon and a slab was given at that point in time. But subsequently, she's had multiple repeated infections and has been immobilized for about 2 years during this last, from the time of the infection. She does have intermittent painful episodes, but those are relieved with analgesics. Next slide, sir. So at presentation, we can see that there is some functional difference. Could I ask one of our panelists, ma'am, Rujita ma'am, could you just describe the functional deficits on this clinical picture, please?
Sure. So what happens is most of the times infection is very much trivialized in our setup between the general surgeons and the orthopedic surgeons. And what they don't really pay attention to, that is along with debrima, especially in the forearm, you have a complex and interrelationship of two bones, which is very, very important here. So even if the infection subsides and the debrima and things kind of come underway, the pronosupination invariably gets affected. Since these are long-standing cases and they are very often neglected, they tend to be brought to you as a pediatric orthopedic surgeon only once the functional deficit is really, really fixated and kind of really in the way of the child. And by then you will find, if you see an X-ray now, I'm just predicting the X-ray, you will find a very gross mismatch in the diameter of the affected bone. The functional ranges are not really functional. They are just like a 30-degree non-usable range. And then reconstruction becomes difficult. Progressively, the DRUJ and the proximal radial ulnar joint, all are going to give you trouble as you go along. So you have to keep a lot of options in mind, especially if you've not spanned them from the beginning. Dr. Bobby, any take from you on this?
Yeah, sure. I think I agree with all of what you said. But additionally, the way I look at it is, number one, is it her dominant or non-dominant hand? One, I would like to add on that. The other thing is, the whole issue is the laxity in the forearm, which eventually will affect the function of the hand. Right? So I think at the end of the day, you have to keep that in mind. Whatever you do, you need to do to improve the efficiency of the hand. So
Bobby, what I would like to add here is that when the child has a problem in very early childhood, that means neonatal period, their hand index change. That is what happens even in hemiplegic cerebral palsy. Because this girl had problems since age of 4 months, she has definitely become right-handed. Maybe she was intended to become right-handed or probably became a right-handed. But if that had happened in right, she would have shifted to left. That we see compensation very often.
Agreed. But she's, she had this infection at the age of 5 years.
No, 4 months.
4 months. Okay, I'm sorry. Yeah. I read 5 years. Yeah.
Okay.
So that's the X-ray that is being put up, and as predicted by our panelists, we can see that the ulna is there's a non-union. It's shorter. The radial head is subluxed and deformed. There is a slight bow of the radius as well, and so all these points have already been brought up. So I'll just quickly ask sir to now, with this X-ray in mind, we could think about the treatment options that are there. Like if I can go back to Dr. Bobby, sir, if you could give us some thoughts about how to proceed.
Sure, Abhi. So here, what we need to realize is, the problem. You identify the problem. One is virtually no ulna. Now the elbow looks a little distorted, but however, clinically the function seems to be good as far as the elbow is concerned. And definitely the head is lying dislocated. And, you work on the presumption that the ulna makes the elbow and the radius makes the wrist. So if the function of the elbow and the wrist is good and the function of the hand is good, I think this becomes a good case to consider it for a one bone forearm. So I would, work on making it a one bone forearm. However, the only other issue is whether I should do anything to the head of the radius at the same time or at a later date.
Could I get Dr. Rujita ma'am's perspective also, please?
So if we have to look at this, especially in the light of what was discussed yesterday, there are multiple problems here, beginning from the growth of the ulna. Although there is a decent epiphysis there, there is a very strong tether at the DRUJ. It's a very small ulna. I would call this almost an infantile ulna. It's like the ulna has remained in that 4-month age and the rest of the bone has grown. So that itself tells you that there's not much potential there. The edges are atrophic. The coronoid and humeral articulation also has evidence of infection over there. So therefore, your range ultimately would only be limited. And with the radial bow and the radial head misshapen so badly, even if you do reconstruction here, you probably will be, doing it in multiple stages. At each stages, there are going to be pluses and minuses, whether your fibula unites, whether you get a good lengthening, you may have a non-union there. So if we are going to look at ultimately the patient and not the X-ray, I think one bone forearm is not a nihilistic option here. I think it is actually going to do service to the patient and get them back immediately as fast as possible to their functional rehab.
So thank you for those thoughts.
So I think, Rujita, you said it nailed it very nicely. This is a girl of truck driver. They cannot come back and forth. There are financial issues. That is why they had to wait for 10 years for coming to me. So I think if we can give a good result, lasting result with minimum procedures at minimum cost, that will be probably very apt for most of our patients. So I agree. We also considered on those lines and we have went ahead with what you and Dr. Bobby both suggest.
So we can go to the next slide. So those are the operatives. I'll ask Dr. Premal sir to please take us through these steps since he was the operating surgeon.
So we just did a one bone forearm. I put a nail, but then we thought that the stability was not adequate. So just put a plate there and added a local bone graft from the excised bone. Take over, Abhay, please.
Yes, so here we can see the follow-up images of the one bone forearm, and interestingly, as the original site of union unites well, the radius also appears to be contributing to the overall picture, and there is the periostal sleeve that probably was intact, ossifying and throwing new bone, adding to the stability. So this is the follow-up image showing a good position in neutral position, or in inverted commas mid-prone, as we might call it. But and at follow-up, the radial head position also is improved, though at this point it's probably superfluous and would only be an issue if it was blocking flexion to some extent. And in that case, it could be excised. And that's the follow-up showing nice cosmetic results and good functional improvement as well. She does have the supination, but that's probably coming from the humerus and from the shoulder joint. But that's not cosmetically unappealing and is serving the purpose quite well. So I think overall that's a good outcome with an excellent choice considering the socioeconomic situation that the patient was in. So just to kind of sum up, there are multiple options in this situation, and probably the best choice would be based on the social situation of the patient and the experience of the surgeon, as well as the the number of times they can come for follow-up. So thank you, sir. I'll hand over.
Abhay, thank you very much for an excellent case discussion. We move on to Dr. Sakti Das, who will be presenting Maitland deformity, management options, and long-term follow-up. Dr. Sakti, please start.
Yes. Good morning. I will present a rare problem that is mid-lung deformity. That is basically, this is a deformity of the mainly wrist and forearm. And this is described by the German surgeon Otto Medlung in 1878. This is characterized by radial bowing and ulnar head prominence and volar carpal subsidence. The deformity arises from the combination of the partial distal radial facial arrest, mainly volar and ulnar aspect of the radius. And specifically, this mid-lung deformity is having a hypertrophic ligament known as vicus ligament, which is spanning from the volar aspect of the radius to the carpus. And there may be similar type of wrist deformity in trauma or infection. It often presents bilaterally and as a female predominance. Next, please. Basically, my question to my panelists, what are the other causes of this deformity? Mainly, this is a problem.
Pascal, can you answer this question?
Problem. Yeah.
I think the repetitive trauma may be one of the cause. Common in females, or as I said, it's common in adolescent females more often. And maybe those who are into sports activities, which like gymnastics, or where there could be more pressure on the wrist, is one of the reasons leading to bar formation in the distal radius.
Sometimes also in infection. And as well as this, without X-ray also, sometimes this multiple exostoses involved in the also look like that also. And also this is sometimes a genetic problem also, Larival dyschondrosis. That's a bilateral and also familial. Next, please. So this is a radiological feature. Sometimes a osteolytic lesion is seen in the lower end of the radius. This is basically the ligament attachment from this point to the carpal bones, and also this carpal subsidence. These are the radiological features described by Mackerel and James. This is ulnar tilt, means articulars of the radius, how much it tilted, and palmar carpal subsidence, how much carpal has progressed on volar aspect, and lunate, how much lunate has pushed inside the ulnar joint, as well as the ulnar variance. These are the radiological features described. This is my case. Is a male child, a male up to 15 years old, having bilateral involvement. Next.
Dr. Sakti, can you see the images? I think you seem to be frozen.
So this is the X-ray. All the features of the I'm able to see.
Yeah, please go ahead.
Okay. So all the radiological features, like what we discussed about the carpal subluxation and the radial tilting, yes, it is there. Next. So what are the management options? My panelists, what are the management options? So it is the slide still.
So if I could take this one, so so in this child who's 15 years old, who's got an obvious deformity and definitely some functional issues, I would think that a surgical option would be appropriate. So the surgery should involve excising the vicus ligament, and the osteotomy described is a distal radius dome osteotomy done through a volar approach that allows both the excision as well as the osteotomy fixation. Could be with just wires or with a plate. In a younger child, probably there could be an option of an excision of the vicus and an epiphyseal lysis, or even a guided growth if the deformity is not substantial. But at 15, I think all those are moved, and what we would have to do is go with the surgical correction of the deformity.
How early you see this case? Usually they come in this age group, basically. How early? Yes. The excision of the vicus ligament has been described, but it is very difficult to do in this type of age because it is very difficult to diagnose also, because they don't report any opinion. Have you? But the minimum age you have seen this problem.
So as you say, in our situation, I think it is seen in older children. Very well, if they come for evaluation of short stature, then it is possible sometimes to pick them up earlier. But yeah, definitely in our circumstances, they would be only in this adolescent age group.
I think that's fair enough, but mostly I would agree with Dr. Das that they come very late. So let us see what Dr. Das did.
So all the cases, whatever I have done, I have only done this procedure. Volar approach to the lower end of the radius. You see, this is the pronator quadratus. Then next slide, please. Then this is the Vickers ligament. This ligament has been excised. And also then followed by a dome osteotomy. Next, please. So this is my osteotomy. I correct the deformity, then fixed with K-wires. Next, please. This is both the cases. I have corrected the deformity by the dome osteotomy as well as the fixation of the K-wire. And this is on the POP removal, both sides. The deformity looks corrected. Next. Next, please. Yes, this is a functional recovery. This is dorsiflexion and palmar flexion. Sorry. Okay. Then
so this is
other
just
options.
another option. Yeah.
Yes, this is an option about the JES. Dr. Rojuta, can you describe how you do it?
So what happens is with the mid lungs, when they come at various stages, especially if they come with pain and with severe carpal subluxation, adding a fixator on helps you to control with ligamentotaxis. You can additionally use just one pin for a better hold in that distal metaphyseal fragment because it's very small, and that gives you a much more secure fixation. Otherwise, with the dome, I find that very often it just tends to crush the thing and the dome is not really retained at the end of it. So it's just that in my hands, I feel it's easier to work with this and retain your DRUJ better. You can adjust the problems there, and you don't then really need to go in and do a shortening of the ulna since you have really distracted it out. And this is metaphyseal bone, so it unites very well all the same. So that's just to show you a quick result. And let's move on with the next case.
This case by Dr. Premal.
So I think if you want to lengthen, this is another option where you can do lengthening and adjust the fragment. This is just another option. So we move on to an interesting case of elbow injury by Dr. Rujuta.
So this is a child who had come to us with a standard thing that occurs in all over our country. Next slide. Typical supracondylar. This is what we got on the retrospective history. What she came to us was with a totally stiff hand in extension. Typical supracondylar, just treated with a slab somewhere aligned, and probably multiple attempts in the OPD to get it reduced well. No GA used either. And they thought that this alignment was reasonable, so they proceeded with the conservative management 2 years ago. Go ahead. And this is what the child came to us with a complete extra-articular bony ankylosis and absolutely no question of a jog or anything, no other history available in between. So any of my panelists, would you like to opine? What would you like to do at this stage?
Can I take this, madam?
Premal or Rajiv? Yeah. Okay, yeah. Rajiv, you go first.
Yeah, so we would like to investigate further and see the extent of this myositis mass. And as you had said that this is an extra articular myositis, if possible, we can try to resect it, but preoperatively planning for this case will be very essential because this is a anteriorly placed myositis, and we have to be very careful about the neurovascular structures which are there on the anterior side.
What would be the range of movement that you would perhaps be able to predict? Do you think that, Premal, in your experience, do you think that there's any gain at all by venturing into this sort of a situation?
I think this is will be a very rewarding case. All myositis excision in front of elbow generally gives a good cosmetic, good functional result. And one thing I would like to add is what I generally do is once I excise the mass, I would evaluate what is the range of movement per operatively, maximum extension and flexion. And at final follow-up, generally that is the movement which comes. It just doesn't come beyond that. So I generally document the picture of maximum extension and maximum flexion at the end of my procedure. And I'll tell my patient that if you get that much of movement, you are lucky, really.
What would you say, Premal? What defines the success in a myositis? When should you intervene? Should you intervene in every myositis case, or should you refrain? Or there are specific pointers that this is when you will think of excising the myositic mass?
The first thing is, if you don't have functional range of movement, you will have to excise myositis mass. If, generally, it is not painful, so pain doesn't count here. The only thing is, once the myositis is matured, that is the only time you can excise. So it may be a good idea to do serial ESR and alkaline phosphatase evaluation, so that once they become steady or they start falling, that is the indication that the myositis mass is mature. And that is the only time you would like to go ahead and excise that. But of course, if you expect that you will get 100% movement, that may not be a good idea. It may be a good idea to have a nice and healthy discussion, realistic discussion with the parents, that what both of us are going to undertake and what is expected of the procedure.
So I'll go ahead with this. I think that these were the precise thoughts in our mind, because it was a mature myositic mass. It was very well defined. Although there was a virtual bridge from the lower end of the humerus to the upper end of the ulna, we decided to investigate with two modalities, both CT and MR, and which clearly showed that the ulnar coronoid articulation was very well maintained. And we anticipated that the neurovascular bundle will be a challenge on table, especially to differentiate it from the rest of the fibrosis. So go ahead. This was her range. She was totally fixed in 40 degrees of flexion, unable to even bring the hand to the mouth. And that's the reason, although it was a non-dominant extremity, that's the reason that parents came to us. So we took a very generous incision with the help of our planned colleagues. We marked out the mass, if you can point it out with an arrow, the X-ray, the Siam picture. And we decided purposely to go a little low, although on the humerus also you can see a very clear line defining the shaft of the humerus with the rest of the myositic mass. The first priority was not to do any harm, and therefore we did not proceed unless the entire neurovascular bundle had been isolated and kept aside by our plastic surgeons. And then intentionally, bit by bit, piecemeal, we went on excising only on the humeral side first. We purposely left a little undercorrected because this is very prone to pathological fractures, maybe very tempting to rather iatrogenic fractures. It may be very tempting to over excise on table because you're overzealous and you think that the entire mass is coming out. But sometimes you don't know, you may enter the shaft and just enter the medullary canal, and that's certainly not a good idea. And that was the range that we could get on table, about 40 degrees more, which we had preoperatively counseled the child. Go on to next slide. And that is, we protected her. What we did here in addition is that what we find is that on table, the range that you get usually goes down significantly post-op because the body tends to replace it by the same tissue. So purposely, like an interposition arthroplasty, we used fibrin glue wrapped in Surgicel and we placed it at the site of the excised myositic mass to prevent a re-stenostosis. And it was like a foreign body which kept the thing like an interposition arthroplasty. And immediately started on oral indomethacin and mobilized her. We kept a catheter, epidural catheter, not an epidural, but a clavicular catheter with the help of an anesthetist. And we kept her pain-free so that we could start mobilizing her in the first week itself. And that really helped with gentle mobilization. Go on next. And now that's her range of motion at 1 year follow-up. You can see the LIGA clips over there. The scalloped or excavated humerus is now done well, and that's only a little bit anterior spur, and she has about 40-50 degrees range of movement. She's able to go to the take the hand to the mouth as well, and she's doing quite well. Anybody else on the panel wanting to talk about radiation in such cases?
The only thing is how much time we will prevent this with indomethacin.
So indomethacin is given for 2 weeks post-operatively, and it is largely, I think, since it was a mature mass and it was quiescent, we went in only in the cold phase that the body did not throw up any more bone. I think we'll move on to the, this is a literature review for any of you all who wanting to look at it. We go to the next slide and the next case so that we can achieve more cases in the discussion.
Yes,
Dr.
Dr.
John,
Please
please.
go ahead.
Your turn.
Dr. John?
Yeah, there. So these
Yeah.
are the, so this is a 14-year-old boy who presented with a Volkmann's ischemic contracture of his non-dominant left forearm and hand 3 years following a supracondylar fracture of the humerus. Next slide. And these are the clinical images which show a scarring in the front of the forearm and involvement of all the fingers, including the thumb. Next slide. And he has a reasonably severe flexion deformity of the wrist with hardly any extension, though he had a reasonable pronation supination. So if I might ask Dr. Chasanal, how would you proceed to plan this out? Yeah, maybe you can just show her the next X-ray as well. So this shows a healed supracondylar fracture. Dr. Chasanal, would you like to tell us your considerations for making a plan for this patient?
So, I think we could probably go for staged serial casting for this child if it's possible to stretch out, or maybe a orthofit kind of splint if it works in your setup, which we could help do gradual stretching, and maybe then whatever the residual contractures is, maybe do a release like a flexor pronator release, or entire, even it might need probably FDS and FDP fractional lengthening also. So probably a full flexor pronator as well as finger flexor fractional lengthenings.
Perfect. I think that should really be the plan ahead. Now, the challenges here were logistical. This patient comes from about 300 kilometers away, not socioeconomically disadvantaged. So we don't really expect them to come back for a regular follow-up. So that is what dictated what we did for this patient. So the next slide, please. So we went ahead and made a diagnosis of a moderately severe Volkmann's ischemic contracture. And instead of being able to sort of stretch it out sequentially, we decided to go ahead and do a muscle sliding procedure. Next slide. So this is the incision that was marked. And this is the correction that was achieved at surgery. Dr. Abhay, at this point, having bypassed stage 1 and gone on to stage 2 and done this and achieved this correction, what challenges would you anticipate?
So the first challenge would be the viability of the skin flaps. While the picture has taken adequate precautions, the angles of each of these Z's is probably about 60 degrees or maybe slightly less than that. But the pre-existing scarring could face a challenge. So the immediate post-op would be maintaining the correction because that would put a certain amount of stretch on the skin, and that can be an issue.
Exactly. So that's what happened. So now when we look at the images post-op, on day 3, we saw blistering of the blisters along the entire length of the incision. And by day 4, there was marginal necrosis. So the question here was, whether to continue with working on retaining the correction that we got or to back off. So we decided to back off, allowed the swelling to come down, the suture line to heal. Next picture, please. And over a period of time, the wounds had healed. Having said that, at about 1 month, we went ahead and started to stretch the deformity back again in plasters. Next slide. And at about a year and at the end of a year and a half, we achieved, the question was, what did we achieve? Now, when we look back, here is a child who wasn't using his left upper limb even to support anything while using the right hand, though he was right hand dominant, was able to at least hold a glass, pronate, supinate. And next picture. And we even managed to help him with pinching and grasping to a certain extent. So the next question is, when we reflect on what we did, next slide, please. So the questions that came up is what went wrong? Dr. Chasanal, would you like to comment on that?
So I think the incisions made a little more acute at the apex, what I felt. So probably
Right.
they would be more lazy, yes.
Right.
And probably 2 incisions would have been a better option. One for the flexor pronator slide and one in the mid third. Probably. Maybe. I mean, this is just retrospectively my opinion, maybe, but on table you thought a single
Fair
one
enough.
was better. Yeah.
So I agree with you. I think the incisions could have been a little less wavy. And even if we went in and did it in one stage, maybe we could have left some tagging sutures and then gone back in maybe at about 48 to 72 hours and done the rest of the closure once the swelling came down, was one thought, in hindsight.
There's
And
a question from Dr. P.N. Gupta. He's asking Dr. Bobby John, would you have considered using a turnbuckle cast?
in hindsight, yes, maybe. Now, the only issue here is a child who comes away from, it was more a fear that we wouldn't get him back for follow-up. That is what dictated. The reason I brought this case up is I'm sure a lot of us do see patients who come from far away. And these are surgeries which need a close follow-up. So anything that you do where you can get them back even at a weekly interval should be good enough. So that's my take on that. So, I mean, I would like to thank Dr. Abhay and Dr. Kiran from Vellore for having shared this slide for an alternate approach for a Volkmann's ischemic contracture. Abhay, do you want to just comment on this?
So this is a slide shared by one of our hand surgeons, Dr. Kiran Sashi. They tend to use a medial ulnar side incision for all their slides as well as their compartment releases. They don't do the classical two incision approach, and they do have a good exposure through it. So I don't have any personal experience with this, but this is from the hand surgeon's side. So this could have been an alternate incision in case of bad skin, as in the above case.
Great. I think we will just sort of summarize the whole thing. At the end of the day, I think principles apply, and you need to follow principles of correction in situations like a Volkmann's ischemic contracture. Thanks,
Dr. John, one last question from Dr. Suhas Bala. Any role of bone shortening?
Well, I mean, that would be an option kept on the table if we had to.
Okay, let's go on to the next case. Samir, please start
Yes,
here.
yeah. So we'll be discussing a case of multiple hereditary exostoses, and we all know about Masada's classification, in which type 1 radial head is not dislocated, and in type 2 radial head is dislocated. Type 1 is usually seen in 50 to 60% of the cases. So I'd like to thank Dr. Premal for his case. So let us see a case of type 2B. So this is a 6-year-old child who came with prominence seen over the elbow, and this is her X-ray. Next slide, please. And this is her clinical picture. You can see she has good pronation, limitation of supination, and slight restriction of elbow flexion. And these are X-rays. So if you go to literature, there are views that you should wait till 10 years before you do your lengthening. And Dr. Premal and Dr. Das, what are your opinions about it?
I think if the child has come to you with certain symptoms, and we saw yesterday a case where if you keep it neglected, it really migrates very proximal. So when you have an ulnar shortening with a dislocated radial head of a significant duration, it may be a good idea to tackle this. But at the same time, you would like to warn the parents that this may not be the only surgery which they are looking for. They may need to have another lengthening or another procedure down the line. So if you have patient on the same page with this type of discussion, you can go ahead and lengthen it right away.
Yes, that's a very important point that you must mention and tell them that they may need a lengthening at a later stage. And Dr. Das, what about correction of radius? Do you do it in the same sitting or do you stage it? And in what conditions will you do a radial deformity correction? This child does not have a very high radial articular angle, so this child may not need, but what is your opinion about radial osteotomies?
radial osteotomy in this case is not so high, so I will not correct the radial deformity, and I will start doing the ulnar lengthening, which I expect that length of the ulna will be maintained as well as the.
Yeah.
Go ahead, Samir.
Yeah. So what is the fixator preference? Recently, a lot of papers are coming out with use of TSF. Usually, we are trained in using a just fixator for ulnar lengthening. So, what is your opinion? Does anyone have experience about any other fixator method?
I think Premal, you can take that.
I think this is the most easily available fixator, the JES, and I'm quite comfortable using it. I have started using K-wire assisted lengthening, and I have not migrated to any other fixator because this is universally available, and in my hand, it really works really well. So if the technique works in your hand, never change it. That is what I learned long back.
Another important point is what should be the end point of your lengthening? Will you be happy once the radial head sits in, or would you like to lengthen the ulna a little bit more, more than the radius? Because the child is going to grow, so as to avoid second lengthening.
So Samir, that's an excellent point you have raised, that you should always overlengthen the ulna because you know that the distal end of ulna has stopped growing. So it may be a good idea to create a positive ulnar variance because in a couple of years you are sure that is going to be a negative variance. So I think in yesterday's case, that was probably one of the issues. If you look at this case, that we had lengthened the ulna 1 centimeter more than which was required, and probably you will see the long-term results.
Yeah, so I think so. We'll go to the next slide. What was done was lengthening, and so did lengthening over a nail, and you can see that he has lengthened the ulna a little bit more than the radius, so as to the growth of the radius. And this is the long-term follow-up of the child. This is the 11-year follow-up, and you can see the next slide, please. This is the 14-year-old follow-up, 14-year follow-up, and you can see next slide, please. The X-ray may show a little bit of subluxation, but this child has done very well in spite of all the problems. So this is a very good case with a very good long-term follow-up, and I'd like to thank Dr. Premal for this case. So the other problem that we always see is Masada type 1, where there is no radial head subluxation or dislocation, but the radial articular angle is a little high. And so there are some papers which mention about epiphysiodesis of the distal end of radius. And also some papers mention how to prevent radial head subluxation by doing a distal tether. So what is your experience? Yes.
Rujita, would you like to answer this? How would you take this case?
Sorry, I missed that question because I was looking at what questions are coming on.
So radial inclination has changed in this case. So how would you approach this case? Would you do a radial osteotomy? You would wait? You would try some growth modulation or something?
So yeah, there are two options. Either you could do a growth modulation or you could re-osteotomize and go ahead with the ulnar lengthening and restore the variance, but that parents may not be too. But at least in the between the radius and the ulna, growth modulation definitely works better. Like if you use a PETS in the radius, and in upper limb shortening is usually not an issue too much. So you could definitely try that here.
Yes, Amir, what happened?
Yeah. So what was done was a screw epiphysiodesis, and next slide, please. So you can
Samir, only one thing I would like to say here. What Rujuta said, that you can do percutaneous screwing. Here it won't be possible to do a percutaneous screwing because your radial now as well as your two important tendons come. So you'll have to take a small incision, go right to the bone, and then you put a screw like this. So that would avoid a lot of clinical issues.
And you can see that the radial inclination has improved, and after excision, and after removal of the implant, and the child is doing very well over 3 years.
Yes, I think Rajiv has not there. He seems to have lost his connection. Are you back, Rajiv?
I've come back.
Yeah.
Yes, yes, yes.
He's back, he's back.
So this is, I will run through this case. It's a 10-year-old female. She presented to me with restricted abduction. All other movements were good, and this was the causative factor. So there was a proximal humerus varus. Even her opposite side was slightly abnormal. So Rajiv, what do you think is happening here?
So there is a proximal humerus varus here, and as you said, it is bilateral proximal humerus varus, which is seen in many conditions. It could be a normal anatomical variation also, or it could be seen in some dysplasias. So we found out this paper from Ogden et al. In 1976. And he has mentioned some etiologies that it could be normal anatomical variation, it could be post-traumatic, it could be after a pathological fracture of a benign cyst, could be a skeletal dysplasia, or could be some metabolic disorders, osteomyelitis, hematological disorders, neoplasm, and neuromuscular disorders.
So what
like
will you do, Rajiv? What will you do for her?
if her functional movements are restricted, then probably a valgus osteotomy will help her. A proximal humerus valgus osteotomy will be useful.
And what will be your technique for doing that? And what will be your fixation?
I can probably with a K-wire and a tension band.
Like this, right?
Yeah, so this has been described by Peter Waters in his article, and he does a wedge resection followed by fixation with the TBW and K wires. And there is another method of fixing this described by one of the Chinese papers where they use a plate and resect the wedge and fix it with the plate and screws.
So I think we did the same thing. We resected the wedge and used the locking plate. And this is how it ended. And this is her 1 year follow-up. And this is her radiological union. And this is her preoperative and postoperative function for completion. So proximal humerus varus is not very common, but once you have this, a valgus osteotomy will give you excellent clinical result. So we move on to the last case of brachial plexus palsy by Rujita. Rujita, we have 5 minutes to finish. Please start.
Yes. So please advance the slide. This is a very rare occurrence that you usually see with a baby presenting with upper plexus lesion. And it just goes to show that brachial plexus is purely traumatic in origin. So imagine the degree of trauma in the shoulder dystocia, where I got a call from the NICU where they suspected a dislocation. And truly, when we took an X-ray, as you can see by the arrows, that we found that the humerus was actually subluxated and there was a very large increase in the medial joint space, especially when you compare it with the other side of the humerus and the glenoid. And this was a very severe C567 post-ganglionic injury, which went on to recover in a few weeks. It started showing some amount of recovery. But this is the only indication where I use an abduction splint. Otherwise, by and large, in an OBPP, abduction splinting or the aeroplane splinting, which used to be there in the earlier days, is not really expected anymore. And we got a successful reduction of the shoulder. It went on to show early contractions as expected with the upper plexus lesion. So therefore, we did a Botox for the pectoralis major, the subscapularis, and the triceps, so that the persistent internal rotation of the shoulder was taken care of. And then we put them on a very rigorous rehabilitation program. Go ahead, please. And that's the kind of sequelae, the typical sequelae that she came back with at 1.8 years, the restriction of abduction, clarion sign positive, restriction of external rotation, and the scans showing 17 degrees retroversion and 23% in subluxation, which meant that the shoulder had started moving out. And therefore, nowadays, since the paradigm is to move in early and try and restore the shoulder biomechanics as well as the anatomy, We did a conjoint tendon transfer as well as an anterior release. And that's the kind of result you can see, full abduction restored. We did a fractional lengthening of the pect and a partial subscap, so which enabled us to even give a hand to mouth and hand to back very easily, and good midline function, as you can see here, 3 years post-op. So the point about presenting this case is that this girl was then put into a lot of gymnastics and training, and she came back again with a little bit of a problem at the biceps and deltoid, where they showed a contusion. She had a very severe muscle pull over there. A follow-up scan showed good enough restoration of the shoulder anatomy. But this same child has now come back. As you can see, the retroversion improved at 11 degrees, but the subluxation, shoulder subluxation, had completely settled down.
So Rujuta, can I ask a
go ahead?
question?
Sure. Rujuta, can I ask a question?
There are 2 questions. Who goes first?
Samir, you go first.
Okay, so the external rotators, Rujuta, are known to recover till even 3.5.
Yes.
There are a lot of people who say that you do the release first and then with good physiotherapy, usually that recovers, the nerve may recover. So if you do a transfer in the same stage, what are your experiences with maybe overcorrection? What happens if the nerve recovers? Would you rather do it at 18 months and 2 years? I am a little skeptical about doing a release and transfer together.
Not at all. I think more and more, there's somebody's audio which is still on. Can you mute that, please? So the nerve recovery usually finishes by 1.5 to 2 years maximum, especially in an upper plexus. Your recovery time from the central neuron to the motor end plate in the hand is about 9 months in an upper plexus, classical upper plexus. The lower plexus takes 1.5 years. So once you have a MRC grade 3 powered external rotator, no matter how long you wait, that's not going to come back. And the tendon transfer was described mainly for restoring external rotation. The anterior release only releases the tether, or it only releases the contracture which has set in because of neglect.
Yeah, but so I have seen you just give Botox or do anterior release. A few of my patients recovered spontaneously their external rotation.
So in those, you already must be having a good recovery in the external rotator. So it all depends on the MRC grade of power that you have.
The external rotator is working. My question is then why don't we do it in stages and do a simultaneous? When there is a contraction, how do you know whether the external rotator is working?
No, you can test them in full abduction and external rotation at the shoulder. You can very well make out which muscle is contracting on and not. So that I think can be tested clinically. If you still have any doubts, you could go ahead and do a
needle difficult at 1.5 years to test external rotation.
It's still not impossible, you know. So we ourselves have moved back from doing it at 3 years, which is what we used to recommend earlier, to going in as early as now. And Scott Cozen's papers, Peter Waters' papers, they've all shown.
So Rujuta, let's wind up. I think we are going to overshow otherwise. So
so I'm just stopping this discussion here, saying that it is known to remodel the earlier you do it. The point about this case is that at 15 years follow-up, that was a function which went down slightly. As you can see, the flexion deformity of the elbow came down. And this is what she came with. And I'd like Chasnal or Premal to opine on this, that she came back with a pain in the index finger and the middle finger, sharp shooting pain at 15 years of age. So, Premal, can you make comments as to why this happened?
I think if the shoulder is sagging, there can be some pressure on the brachial plexus, or maybe neuritis kind of picture can come up. But unfortunately, I looked at the literature, it has not been reported. So it may be a very nice idea that if you have a set of patients, it may be a good idea to report them, that in a long-term brachial plexus repair, what are the problems expected. You are one of the centers who could do it actually.
Sure. So this is one case. Therefore, we had a long discussion with Dr. Thatte, and what he seemed to say is that when the shoulders are asymmetrical, especially the heavier the child gets, if the arm starts drooping, they get somewhat like a thoracic outlet syndrome, and this can recover beautifully if treated conservatively. And they've seen similar instances in adult traumatic brachial plexuses, which responds beautifully to gabapentin, but it typically occurs 14, 15 years down the line after even the initial flexile repair. And I taught her a lot of shrugging exercises and put her on 6 months of gabapentin, and she went on to recover quite well. So the point about bringing this case was that it may not always be all is well once you have treated the child at a very early age. You must follow them and watch out for late onset problems as well.
So
we have 2 minutes. We can take another case. Premal.
No, sorry.
So I think we have
it's
also,
already.
we don't have,
Yeah.
yeah. So I think we had a wonderful discussion and a long-term follow-up on unusual and common upper limb problems, and I think people must have enjoyed that. And I will hand it over to Dr. Dhiren Bhai so that we are not late for the second session. Thank you, Dhiren Bhai.
Yes. Yeah. Thank you, Premal and Rujuta, and all the panelists for a wonderful discussion. Now I request, first of all, a small presentation of Uma Surgical, and after that.
તો હમણાં એ રાખે તો એની દવા કરવી પડશે આ એકને
Yes, thank you very much. Now I hand over to Dr. Viraj and Dr. Venkat for the case discussion, for the free paper session. Yeah, thank you.
Thank you, Dhiren Bhai. After a lovely presentation by Dr. Premal and Dr. Rujita, I welcome you all for the pre-paper session again. So today we have total 7 speakers. Am I right, Dhiren Bhai? Venkat?
Yeah, 7.
So, without wasting the time, I think we'll move on to the session. Would you like to give some house announcements again, Venkat?
Yeah, Viraj. Good morning, everybody. So we have 7 papers today, and the time allotted for each free paper is 5 minutes. And at the end of 5 minutes, your screen will go blank. I believe all of the presenters are having pre-recorded talks, and we have 2 minutes for question and answers. With that small announcement, I think we can go on to the first paper, Viraj.
Yeah. So the first presenter is Dr. Siddharth. He is going to speak on adolescent scoliosis pathway, outcomes of predictive post-operative ward-based care for patients undergoing posterior corrected AIS. So Dr. Siddharth, please.
I'm presenting my study on the adolescent scoliosis pathway and the outcomes of a predictive post-operative ward-based care for patients undergoing posterior correction of adolescent idiopathic scoliosis. This study has been done at Queen's Medical Center, Nottingham. It's a common practice to send scoliosis patients post-operative to critical care. However, this leads to increased burden on the intensive care system, increased costs, and this may actually not be needed for adolescents who are physiologically stable. However, there are no objective criteria or treatment strategies to predict and safely guide the optimal post-operative level. Thus, we have devised a scoliosis pathway, which can predict the post-operative ward-based care for these adolescent idiopathic patients. The pathway has been designed based on a scoring system previously published. It accounts for the physiological and predicted surgical variables, which can be easily measured and quantified preoperatively. These include pulmonary function test, thoracic Cobb angle, and number of levels of surgery. The pathway includes 2 checklists. One is the ASA grade being 1 and 2, and secondly, a clinical predictor score, which should be 3 or less for the 4 variables we have just mentioned. There's a rigorous intraoperative monitoring, a strict recovery checklist, and a prescription chart. There's a defined escalation plan for the care of the patient in the ward, and if any escalation criteria is noted, then it is referred accordingly to the on-call pediatric intensive care or the spinal team. We applied the pathway to 54 retrospective patients, predicting the care they could have received and comparing that to the actual care they received, and piloted the same in 12 prospective patients to follow them up post-operatively. Demographically, most patients were adolescent idiopathics with reasonably good pulmonary functions. Duration of GA was around 5 to 6 hours, and blood loss was around 5 to 600 mils. In the retrospective group, from those who are predicted to go to critical care, only 30% needed care suited to intensive care. Rest 70% could actually have been managed on the ward. In contrast, those who were predicted to go to the ward, 94% were treated in the ward, only 5.9% needed some sort of escalation to intensive care level of care. In the prospective group, all 12 patients either predicted to the ward or predicted to critical care, all 12 were treated in ward itself. The sensitivity and specificity, although modest, reflects the retrospective nature of the study. However, more importantly, the negative predictive value reflects 94% being only 1 in 16 patients sent to the ward would actually have some unplanned critical care escalation. Rest 15 would be all right on the ward itself. A positive predictive value of 30% reflects only 30% of the patients admitted to critical care would need critical care level of treatment. The rest could be managed on the ward with the level of care available. Clear established guidelines, nursing plans, monitoring charts, and escalation criteria ensure that there is a effective safety net to pick up any deterioration. It provides confidence and reassurance to ward-based care and gives minimal cancellations. Thus, in conclusion, the pathway is effective, protocol, a rigorous and robust way of managing patients on the ward post-operatively for adolescent idiopathics. It is based on objective criteria which can be easily measured and calculated. It allows a margin of safety while reducing the burden on intensive care and significantly reducing the cost of care and improving the overall outcome and patient experience. We are aiming to finish our prospective data collection soon and with a targeted release of the data sometime this year, and adaptation and replication of the pathway data in our pathway plan, more particularly in other centers, would definitely help in assessing reproducibility of the same. Thank you.
Thank you, Dr. Siddharth.
Do you have any question?
So we don't have any questions from the audience. I can ask one question to Dr. Siddharth.
Yeah.
Sir, did you have any of the patients whom you planned for postoperative care in the ward who needed an escalation and shift back to the ICU or the HDU?
So we piloted this in 12 prospective patients. In none of them there was an escalation needed. In the retrospective group, where we applied the criteria to patients who had already been operated previously, and at which time the conventional practice to send was to HDU to all of them, but we saw what level of care they received, actually, where they required intensive care level of monitoring. In that group, only 2 patients needed some sort of escalation, or those 2 patients would have needed escalation to ITU if they would have been in ward as per the pathway. But otherwise, in the prospective group, none of the patients required escalation to the intensive care.
Dr. Siddharth, do you use allograft for the scoliosis surgery? Do you use?
So we have 3 pediatric spinal consultants. One of them does use, but 2 others don't. So the caseload is a combination of all scoliosis in the unit. So some of them may have a use of it, but most others don't.
And you use cell saver also during
we use cell saver for every patient. We use cell saver, and every case is under neuro monitoring. Yes.
Okay.
And all of them are posterior, or you have a combination of posterior as well as anterior?
So right now, when we piloted the study, we limited ourselves to only posterior conventional AISs. But now in the 2 years, we are doing a prospective data collection in 2 years, which we are finishing in February. In that, we have some anteriors as well, where we could apply the pathway criteria, because essentially the criteria reflects only the pulmonary and cardiac function in an assessment. That does not reflect which approach you are taking for the scoliosis. So it could actually be applied even to anterior cases.
Any comparison of anterior plus posterior, or only anterior and posterior?
Not yet, because anterior numbers are very small, because to have the patients who are going to have anterior surgery and fitting those criteria of the pathway to be able to go to ward is less. Secondly, for anterior, those who are having thoracotomy, none of them go to ward, because they post-operative, they are with a chest drain, so they will need to be in intensive care. The anterior cases which suit for a pathway are the ones which are the type 6 curves, or where we are doing lumbotomy, where they don't essentially need a chest care. So those will be the cases where we may consider. So we just have a couple of cases, so there's not much to compare really. Those are more of isolated cases which we will describe, but otherwise there is no comparative study yet.
Okay.
Thank you.
Thank you, Dr. Siddharth. So we'll move to the next presenter. The next presenter is Dr. Roshan Banjara. He's going to speak on limb salvage in malignant and aggressive tumors of the humerus in children. Dr. Roshan Banjara, please.
Good morning, everyone. Today I'm going to present on limb salvage in malignant and aggressive tumors of the humerus in children, the options of surgical resection and reconstruction. Humerus is the third commonest site of bone sarcoma in children. UV sarcoma and osteosarcoma are the most common tumors. Limb salvage is the standard treatment with wide resection margin is always essential, and amputation may be unavoidable in certain cases. Objectives were to evaluate functional and oncological outcome of different methods of reconstruction after resection of malignant and aggressive tumors of the humerus in children. We included a patient from our database, and functional evaluation was done with MSTS score, and complications and oncological outcome were recorded. Regarding principle of reconstruction, preservation of stability of shoulder joint is important, and movements of the shoulder are usually not preservable. Distal movements need to be preserved. Weight bearing is not required. Regarding immature skeleton, medullary canal is narrow, and small length of remaining bone and soft tissue remain after resection, and limb length discrepancy is expected. For different sites within the humerus, different options are available. Proximal humerus is the most common, and resection is already challenging due to proximity to major vessels and the brachial plexus. Tumors rapidly engulf the muscles, which need to be resected as part of wide margin, and axillary nerve is also sacrificed in most cases, so preservation of shoulder movement is usually not possible. The options of reconstruction include cranial spacer application, intraprosthetic reconstruction, and osteoarticular autograft in the form of fibula or allograft. So this was a patient, 12 years male with young sarcoma proximal humerus who underwent wide resection of tumor and intraprosthetic reconstruction and is doing well at 2 years follow-up. Another patient, 13 years male with osteosarcoma proximal humerus underwent wide resection and cranial cement spacer application, doing well at 15 months follow-up. For diaphyseal tumors, physis is spared, so joint preserving resections are possible. Tumor bone is sterilized and fixed back. Extracorporeal radiotherapy is commonly employed, and intercalary nail plate cement spacer application can also be done. So this was a patient with secondary chondrosarcoma of the humerus who underwent wide resection and intercalary nail plate cement spacer application. For distal humerus tumors can be reconstructed with endoprosthesis. Expandable endoprosthesis are available with cost limitations, and osteoarticular autograft using fibula or allograft can also be done. This was a patient with extensive Ewing sarcoma distal humerus who underwent wide resection and extraarticular ACRT. Proximal osteotomy was fixed using plate. For extensive involvement, composite methods of reconstruction can be used, such as allograft prosthesis composite, ACRT prosthesis composite, or nail plate cement spacer. This was a patient with extensive Ewing sarcoma of the humerus who underwent wide resection and ACRT endoprosthesis composite. For even more extensively involved cases, amputation may have to be considered, but surgical phocomelia is an option where remaining joints are fused in functional position whenever possible, and it enables patients to use hand for certain activities. So this was a patient with 4 years female patient with extensive Ewing sarcoma of the humerus for whom none of the methods were feasible. Customized incision was used to aid lateral closure, and entire tumoral segment removed along with the skin. During reconstruction, pouch was created in axillary region to sit vascular bundle, and ulna, soft tissue around ulna was sutured to octomian process. In 31 patients, median age was 13 years, 19 patients were male. For 29% had metastasis, and most common diagnosis was osteosarcoma. Proximal humerus was most commonly involved, and endoprosthesis and cement spacer were the most commonly performed procedures. Median follow-up was 21 months, MSTS was 20, and 6 patients died due to disease. 4 out of 5 alive patients have pulmonary metastasis. Regarding complications, implant failure occurred in 3 patients. Loosening occurred in 1 patient at 15 months at 4 years follow-up who underwent revision. For broken implant, a patient underwent revision and refixation at 3 months. Out of 3 patients with local recurrence, 2 patients have undergone shoulder disarticulation. So Manfrini et al. Reported best outcomes with biological reconstruction, while Dubin et al. Recommended endoprosthetic reconstruction in those with minor bone loss, while biological methods were recommended with major resection or poor bone quality. For diaphyseal tumors, tumor bone sterilization and friction was recommended, and for those with poor bone quality, endoprosthesis reconstruction was recommended. Hendricks et al. Recommended megaprosthetic replacement for distal humerus, but also reported high revision rates. So in our study, cement spacer and endoprosthesis were most commonly used with good results. Composite methods were used for extensive resections, and focal reduction can also be offered as an alternative to amputation. So to conclude, resection and reconstruction for sarcomas of the humerus is unique and challenging. And shoulder joint stability and preservation of function restored to shoulder are important. Extent of involvement guides reconstructions, and shortening is not as disabling, and the results are encouraging. And the first video shows a patient with osteosarcoma humerus at 15 months follow-up with good function, and the happy child is being able to use her hand at 12 months follow-up post. Good morning, everyone. Today I'm going to present a limb salvage in malignant and
Sure. Yeah, thank you, Dr. Roshan. It was really a nice presentation and lovely cases you have.
Yes,
can I ask you one question, Dr. Roshan?
Yes.
What is the survival of osteosarcoma and Ewing sarcoma in your cases? And do you have any comparison with the available literature?
In the Western population, it can go beyond 65 to 70% 5-year survival. But at our center, we have observed that it is does not reach up to 50% 5-year survival. Less than
osteosarcoma or Ewing?
Ewing sarcoma has even less percentages. Actually, it can be between 40 to 45%.
But actually, the Ewing sarcoma, the survival is better. If you see follow the neoadjuvant chemotherapy protocols, then the survival of Ewing sarcoma.
Yes, sir. Yes. The patients respond very well to chemotherapy initially, but while we follow the patients for longer, we observe that patients with osteosarcoma are doing better than patients with Ewing sarcoma. The chance of recurrence and metastasis are more in Ewing sarcoma.
You can just evaluate what are the points why you are not having the better survival Ewings, because, right? So you may have to. And secondly, when you use reconstruction, do you use a mesh for the proximal humerus?
Yes,
mesh?
sir. We routinely use Prolin mesh, sir. We use Prolin mesh in almost all the cases.
All cases. So yes. No comparison of not using or using. Does it really help other than attachment of the tissue? Does it help?
We apply Prolin mesh for stability of the shoulder joint, because no movement. All attached muscles have to be removed, so mesh has to be applied for stability of the shoulder joint.
Okay, Venkat, you can go ahead.
Now we can move on to we don't have any questions from the either the delegates or the panelists, so we can move on to the next paper, Viraj.
Thank you.
Okay.
Thank you,
Dr. Roshan. Yeah, it was lovely cases, and I think you must go into depth and you must publish, because they are very important cases and you have good series of cases.
Yes,
so
sir.
You can just work more on that.
Thank you.
Thank you, Dr. Roshan. So our next presenter is Dr. Anil Agrawal. Dr. Anil Agrawal is going to speak on septic sequelae of hip in children, clinico-radiological outcome of minimal 5 years follow-up. Dr. Anil Agrawal, please.
From Delhi. The topic of my presentation is septic sequelae of hip in children, clinico-radiological outcomes at minimum 5 years follow-up. The infantile hip is prone to complications after infection, and the reasons can be many. And the sequelae hip can include a variety of manifestations, including acetabular dysplasia, instability, or a deformed proximal femur. Choi in 1990 gave a classification of septic sequelae of hip in which they are grouped into 4 categories based on increasing severity of involvement. The literature is scanty on what is the ideal method of treatment of sequelae hip, and only a few series describe long-term outcome for this pathology. The current retrospective series was carried out to examine both options of treatment and had a minimum follow-up of 5 years. There were 8 hips in 6 patients in the observation group and 12 surgically intervened hips in the other. The outcome assessment was done using Moon's clinical criteria, which includes cross-leg sitting and squatting, which is so commonly practiced in our country. Let me explain the main findings of our series through a few case examples. Following infantile hip infection, this child had a Choi 2 presentation, and on serial observation, the Choi type changed to 2B. Another example. This time with a bilateral hip involvement. The joint type again changed over time. To sum up findings in this group, the earlier joint types are compatible with satisfactory clinical function without any surgical procedure. The same joint types can fare different clinically and expect a poor prognosis if the child has multiple joint involvement. As far as group 2 is concerned, the surgical intervention helped improve the clinical function despite no change in joint type as illustrated in this example with joint 4 hip. Another example, there can be occurrence of late changes in the septic hip which could deteriorate function as seen on left side in this child at a follow-up 17 years. The initially stable hip has now deteriorated into a subluxating hip and the function is just overall fair. To sum up the findings in the surgical intervention group 2, there is particular benefit of surgical intervention in joint types 3B and 4A as clearly seen in the chart above, and expect a improvement in clinical function in 4B even if there is no radiological change. With current surgical options, the infantile septic hip is now no more a disease of dismay. We have now more specific information on how to manage a particular sequelae rather than following fixed protocols. Our study also brought out the limitations of the radiological classification in current use. There is no fixed time frame beyond which you can classify the sequelae hip as a particular child type, and various authors have used different time frame for this purpose. Another finding was that there is a poor clinical correlation and with the joint type, and it is determined by several other factors such as multiple joint involvement. To conclude, joint type 1 and 2 can be managed by serial observation in most cases. Surgery will improve results in other types. The most common long-term result clinical function expected in sequelae hip is in joint type 2. Thank you.
Good morning.
Yeah, thank you, Dr. Anil. Nice cases, yeah, nice cases and nice presentation as well. There is a question from the audience.
Yes, sir.
Thomas is asking, what made you to do the surgical intervention rather than just observing the cases?
Sir, this is a retrospective series, actually not a prospective series. So the results are analyzed after the surgery was done. But most commonly, the type 3 and 4 will require a surgery. But type 1 and 2 can be serially observed if the antiversion or the virus is not severe in type 2.
Yeah, thank you, sir. And there is one more question from Dr. Rujita. Do you recommend that CHOI classification should be applied only after age 5? If so, why?
No, sir. Our study didn't show that. If you examine the literature, the clinicians have used the CHOI classification even after 6 months, or say in CHOI type 4B, the many clinicians have used even after just 8 months time because the head is not going to form. So it is not necessary to use the classification after 5 years of age. Initial CHOI gave it after 3 years, but you can find variations in the literature.
So based on your observations in your case series, what is your recommendation? Do we need to follow a particular classification system or just?
We need to improve this. There are no fixed guidelines. We need to find an answer to this, sir.
I think your center must be having a lot of cases. I think you should probably come out with guidelines for these difficult problems.
Yeah, and again for the neglected one, sequelae, I think there are no good guidelines. So maybe if you have last series, you can come out with a good paper, Anil.
Yes, thank you.
Thank you, Dr. Anil. Thank you so much. Are there any questions from the audience, Venkat? No more question. I think we can move to paper.
That's it. We can go on to the next paper.
Yeah. So the next paper is by Dr. Abhilash Srivastav. Is going to speak on allograft in pediatric spine.
Hi, I'm Dr. Abhilash Srivatsa from Indira Gandhi Institute of Child Health, and I will be talking about the use of allograft in pediatric spine. Irrespective of the etiology of kyphoscoliosis, the treatment strategy remains the prevention of progression of the curve and fusion. This is achieved by instrumentation and augmented by bone grafting. Autograft is the gold standard in bone graft, but its use is limited by complications such as bleeding, fracture requiring a separate incision, pain, and prolonged anesthesia time. Also, its quantity is greatly limited in pediatric patients. Hence, we have shifted to the use of allograft, which is available in unrestricted quantities and the quality of which has become more reliable. The purpose of the study was to determine the efficacy of the allograft material. Our materials included patients with kyphoscoliosis requiring correction and patients who consented for allografting. The diagnosis of scoliosis was established and the type and the magnitude of the curve was then determined. All patients underwent instrumentation and fusion. All patients underwent pre-operative evaluation with X-rays, CT scan and MRI, and patients were categorized into two groups. That is, short segment patients requiring 6 or less segments to be fused, and long segments in which patient required more than 6 segments to be fused. The allograft quantity was determined or based on this classification. Our patients were children aged between the age of 2 to 16 years who were fit for surgeries. The minimum post-operative follow-up was 12 months, and patients with osteopenia, dysplastic, neuromuscular curves were excluded from the study. We had a total of 63 patients who were operated by a single surgeon using the standard posterior approach. The desired levels were instrumented and appropriate osteotomies were performed to correct the curve. This was then augmented with allograft, which was mixed with local autograft. The local autograft which was available was negligible in quantity. This is the clinical photograph showing the bed of allograft after instrumentation and correction. Post-operatively, patients were mobilized out of bed after 5 days with a brace, which was used for only additional support. And the children were regularly followed up at 1st, 3rd, 6th, and 12th month and half yearly thereafter. At every visit, patient satisfaction was noted, and the fusion mass, Cobb's angle, and implant stated were noted from the radiographs. Complications, if any, were noted and dealt with accordingly. We had 14 patients in the short segment group, out of which 6 were boys and 8 were girls. The average follow-up period was 24 months, in which it was noted that the mean Cobb angle reduced from 53.57 degrees preoperatively to 26.02 degrees post-operatively. There was a loss of correction of about 1.36 degrees, with no patients having allergic reaction, wound dehiscence, or infections in this group. 49 patients were included in the long segment group, out of which 35 were girls and 14 boys. The average follow-up was 20 months. The average Cobb angle reduced from 55.54 degrees to post-operatively 26.81 degrees with the loss of correction of 1.34 degrees. 2 patients had serious discharge from the wound, which was managed conservatively with antibiotics and dressings, and 2 patients had infections which required a debridement. This is a 14-year-old girl with congenital kyphosis. Which was instrumented and fused. At final follow-up, the patient was very happy, very satisfactory, and a fusion mass was visible on the X-ray. This is a 10-year-old girl with congenital kyphosis who was instrumented. This child had some serious discharge from the wound in the post-operative period, which was managed conservatively. This was a 14-year-old girl with adolescent idiopathic scoliosis, again, which was fused. The final follow-up X-ray show good fusion mass. This is one of the younger child, a 3-year-old child who was instrumented at the age of 3 for congenital kyphoscoliosis. At this stage, the child had a very good result, but post-operatively, as the child grew, the patient had subsequent prominence of the implants and bursa formation, for which the child underwent implant removal. This happened because the bones were mostly cartilaginous, and as the bone grew, the screw lost its purchase and backed out. We had our
Abhilash?
Yes, sir.
Yeah, maybe you overshot time in presentation. That's why it stopped immediately.
Yes, sir. Yes,
it was
sir.
a really nice presentation, and you have a good volume of cases.
Yes, sir.
Now there are a few questions. One is which kind of method you use to sterilize your allograft? That is number one.
So we get an allograft from bone bank post TKR cuts. So they use E2O and glycine oxide to sterilize the bone graft and give it to us. Now, scoliosis surgery is a very planned surgery. So we decide 1 week earlier how much we are going to use allograft, and we tell them a week earlier so that it is easily available for us on the operative day.
Yeah.
How do you decide? One of the delegates have asked unrestricted quantities of allograft.
Yes, sir.
How do you decide how much to ask?
So if it is a long, short segment allograft, then less than 6 segments, we ask for 8 grams of allograft. Now, for every 4 segments that we add more than the 6 segments, we double our quantity of allograft, sir.
Okay. Now, Abhilash, when you use the allograft, it is a normal phenomena that you might get a serious discharge for some period of time.
Yes, sir.
Do you explain this to every patient? Because
we do tell them that there is a chance of you having some serious discharge from the wound, number one, and number two, there is less than 0.1% of you contracting some infection because of the allograft. We give them a full detail and then take the consent, and only then we take them up for allografting.
How do you differentiate then the serious discharge could be just a reactive serious discharge or it is an infection? How do you differentiate?
So every patient, 3 patients had serious discharge. For all 3 of them, we sent a culture sensitivity, opened the suture where there was serious discharge and waited for the report to come back. Only we saw that all the 3 patients didn't have any growth on the culture sensitivity. And then we decided probably it is because of the allograft and the immune reaction due to the allograft and not because of an infection.
Okay.
And how do you prepare your allograft? Do you use any antibiotics intraoperatively?
We usually don't use an antibiotic for a primary surgery, sir. But these days we are doing a lot of revision cases in which we mix the powdered allograft with vancomycin and then place it in the bed.
Yeah. There is one more question from the audience. Why allograft fusion for 3-year-old and not growing rods?
I didn't get you, sir.
One of the delegates is asking the question, why allograft fusion for a 3-year-old and not growing rods?
Why are you not using growth rods for a 3-year-old?
So this was a single segment that was involved. So we thought we could fuse that segment and get away without using growth rods. And this child had a congenital heart disease as well. So we did not want to take her up into OT twice or thrice. And we thought we will get away with doing a fusion at that age. But unfortunately, we realized that she did not grow. And her congenital heart disease had a failure to thrive, and the implants became prominent with bursa, and we had to revise it and remove the implants later.
Okay. Good paper.
Thank you.
Abhilash, yeah, you can publish in one of the tissue bank journals also. There are good tissue banking journals. Maybe you can think of. We had a published one series when I was with Dr. Zohri long back, maybe around 15-20 years ago, right? So you can try that because that will be widespread to the world then. Okay.
Yes. Thank you,
Dr. Abhilash. Thank you. Thank you so much for a nice presentation. Venkat, can we move to the next?
Yeah, we can move on to the next paper. Yeah.
Yeah. So next paper is by Dr. Akshay Gadia. Is going to speak on analysis of complication in management of early onset scoliosis and Indian scenario.
Good afternoon, everyone. I am Dr. Akshay Gadia, and I'm going to present a paper on analysis of complications in management of early onset scoliosis in an Indian scenario. This study was conducted at BJ Wadia Hospital for Children in Mumbai. Treatment of early onset scoliosis varies from casting to growth modulating procedures to spinal fusion. However, in our country, this treatment of early onset scoliosis is complicated due to various reasons. Hot and humid climate makes it difficult for children to bear cast. Non-compliance is another issue. Moreover, growing rod instrumentations are complicated by loss of follow-up and, of course, cost constraints. Malnourishment and poor muscle cover makes this treatment further complicated. The aims of the study was to analyze the complications in the treatment of early onset scoliosis, either by casting, growing rod instrumentation, or fusion. Children with EOS less than 10 years of age at presentation, undergoing either casting, GR, or definitive fusion, and having 1 year of minimum follow-up were included. Children more than 10 years of age and incomplete follow-up were excluded from this study. This was a retrospective analysis of 29 patients, of which 11 underwent casting, 10 underwent growing rod instrumentation, and 8 patients underwent fusion. Complications were further classified into implant, wound, alignment, and neurology-related complications. We used Smith's classification to classify complications in GR group. Procedures were further classified into planned or unplanned based on the timing of intervention. This table highlights the results from this study. The average number of complications per patient were maximum in group GR. However, it is important to note that age at presentation was more or less same between the casting and GR group, but curves were quite severe at initial presentation in group GR, and also average number of procedures per patient in group GR were maximum. Complications associated with casting was seen in 4 out of 11 patients, of which 3 patients had dermatitis, which were managed by temporary cast holiday and bracing. 1 patient developed chest infection, for which casting was discontinued. In group GR, 7 out of 10 patients developed complications, and each patient had these complications related to implants, either in the form of skin breakdown, implant breakage, implant disengagement, or screw pullout. Further applying Smith's classification for this 7 patients, it was seen it was evident that 4 patients required at least 1 unplanned surgery to manage these complications. This is a case of 36-month-old boy who had a 70 degree of right-sided early onset scoliosis, which was managed by sequential cast jacket. At 1 year of treatment, patient had maintained sagittal balance with corpse angle reduced to 34 degree. This is a second case of a 22-month-old boy who had a right-sided congenital early onset scoliosis, who was managed with growing rod instrumentation. At 5-year follow-up, the corpse angle was within manageable limits with maintained coronal alignment. The third case is of a 6-year-old boy who had a congenital kyphoscoliosis with severe focal kyphosis due to T12 hemivertebra. This patient underwent T12 hemivertebrectomy and limited posterior fusion from T11 to L2. To conclude, regardless of modality of treatment, management of early onset scoliosis is quite protracted and associated with significant complications. Risk of complications is higher in younger children. Casting is effective to keep the deformity in manageable limits, but patient compliance in India is difficult due to dry and humid weather. Rigid curves require a growing rod instrumentation, and parents must be consented for the sequential lengthening and possible complications. In India, children are quite smaller, hence attention should be paid towards nourishment. Moreover, lack of timely follow-up due to socio-economic constraints and lack of availability of facilities in the interiors make the management of EOS more complicated. Thank you.
Good morning.
Thank you, Dr. Akshay. It was really a nice paper because people always speak about their good results and you are analyzing the complications. So it's really, I mean, you need a lot of applaud. Now tell me one thing, why you said that the complications were more in growth rod cases, right? If I'm not wrong, in one of the slides you said.
Yeah, yes. Definitely.
Dr. Akshay, yeah. So what would be the cause for that?
Basically, growing rod patients in the growing rod group, they presented in this study, they had a very early presentation in their age. And moreover, the average number of procedures per patient was again quite significantly high. And as we know, more number of procedures makes this patient more prone for more complications. That's one factor which was noted. Second factor which we found was, if we look at the magnitude of the curve, majority of those patients had very severe curve at their presentation. Again, that makes them very high, one of the very high risk factors for increased complications in this subset.
Okay. So you have 2 questions from the audience. One is, what is the earliest stage you start bracing or casting? And the second question is also related to it, which is, will casting prevent the progression of the curve? Is it really going to help?
To answer the first question, any intervention, first of all, we try to delay as much as possible, but the earliest age we try to push is forecasting is to by the age of 6 years. However, in a certain circumstances where the curve is really catching up, in those cases, we have low threshold to offer any treatment for those patients. And second question, as we know, casting is to keep the curve in a manageable limit while having the harnessed growth. It doesn't really completely correct the primary curve, but it keeps the secondary curve into control, which will prevent an conversion of a non-structural curve into a structural curve later on.
Okay.
Right.
From
Thank you.
surgical point of view, what will be your message to the surgeons, to the pediatric orthopedic surgeons in one line? What message you would like to give in terms of surgery to minimize the complication?
Delay the intervention as much as possible and to keep a close follow-up for the patients. And also a patient education is equally important whenever a surgical treatment is planned.
Okay. Thank you, Dr. Akshay. Yeah, it was lovely presentation, and I must congratulate once again for coming out with complications, and analyzing that. You must present and you must publish this at some good journal. Thank you so much.
Thank you so much.
Venkat, shall we move to next?
Yeah, we can move to the next paper, Viraj.
Yeah. So the next paper is by Dr. Ranjit. He is going to speak on management of syndromic clubfoot using Ponseti method. Dr. Ranjit.
Hi, I'm Dr. Ranjit. I'm from Indira Gandhi Institute of Child Health, Bangalore, and I'll be discussing something about management of syndromic clubfoot using Ponseti's method. Coming to the introduction, Ponseti revolutionized the management of congenital idiopathic clubfoot with his technique for correcting them nearly 6 decades back. He also back then doubted that his method could be used successfully on syndromic foot. Syndromic clubfoot originated much earlier in utero and have been less pliable soft tissue and greater imbalance, leading to greater recurrence and persistence of the deformity. The range of syndromes associated with clubfoot is vast. Some are associated with laxity of the soft tissue, such as Larsen syndrome, cutis laxa, while others are associated with the contractures, such as AMC. Hence, the treatment of syndromic clubfoot is controversial, and many approaches to it have been proposed with variable rate of success. With an increasing favor towards Ponseti method to treat them, these clubfoot can have a higher recurrence rate and high rates of surgical intervention. There is an increased need to understand how these feet respond to treatment, and we present our experience in treating syndromic clubfoot at our tertiary government pediatric center. To assess the modality and outcome of the treatment in syndromic clubfoot is the aim of our study. Methods: the study was conducted at a government pediatric tertiary care center in Karnataka. All children presenting with clubfoot between 2010 to 19 were assessed in detail at presentation. Head-to-toe examination was done to assess other anomalies. Neurologist and genetics opinion was sought when syndromic or neurogenic clubfoot was suspected. Ponseti method of serial manipulation and casting at weekly intervals was started. All children were casted by trained pediatric orthopedic surgeons at a dedicated clubfoot clinic. Weekly assessment using Pirani scoring system was done, and once ready, tendo Achilles percutaneous stenotomy was done. Once satisfactory correction achieved, the children were put on foot abduction brace, and children not responding to casting and with relapse underwent surgical intervention. Children were followed up monthly for first 3 months post-correction and the quarterly for the next 1 year and then every 6 months. The baseline information include diagnosis, age at presentation, sex, bilaterality, previous treatment, if any, and follow-up time. The number of casts required for correction, the need for TAT, recurrence, and other procedures, if any, were recorded. Collected data was analyzed, and we had a total of 1,317 patients treated with clubfoot between the years 2010 to 19, out of which 129 children had associated symptoms. Male predominance was there, and to about 79.1%, and females were about 20.9%. So AMC association was 51.1%, and Larsen's was 9.3%, and others were 39.6%, which included Teeter syndrome, Vickers syndrome, limb deficiency syndromes, Freeman-Sheldon syndrome, adduction thumb clubfoot syndrome, cutis laxa, etc. 3 children had a duplication of foot associated with clubfoot, CT. Results: the average Pirani score at presentation was 5.44. 6 children developed pressure sores, which was managed with topical ointment and cast holiday till sore healed, and then casting was resumed. If the child did not show any improvement after 6 consecutive casts in terms of Pirani score, the child was given a cast holiday for 4 weeks. This was a situation in 18.8 children. 19 underwent PMSTR and 3 underwent Ilizarro external fixator to achieve the final correction. The average number of cast supplies was 13.13. Some children underwent TA lengthening and posterior capsular release at this stage as well. So the average number of casts in AMC is 15.2, Larson's is 15.8, Stator syndrome is 10.1, and others is 4.5. Results: 19.6% of patients had relapse at the end of the first 2 years of follow-up, and with 25.7% of AMC children having a relapse at the end of 2-year follow-up. The children with Larsen syndrome required more casts in our study as we corrected the knee deformity simultaneously with the foot deformity correction. The most common deformity to relapse was a hind foot equinus component, with the mean hind foot score relapse being 1.4 and the mean total Pirani score of 2.54. All relapse children were treated with casting initially, and 17 of these children improved and were subjected to Achilles tendon tenotomy or lengthening with or without posterior capsular release and were given a foot abduction brace. Some children, however, did not improve their score on casting and were subjected to Ilizarro or PMSTR to achieve a plantigrade foot. 19 children underwent posterior medial soft tissue release and 5 patients were managed with Ilizarro external fixator. Discussion: before the adaptation of Ponseti method, the treatment of idiopathic clubfoot usually considers the trial of casting or
Yeah, thank you, Dr. Ranjit.
Yes, sir. Pardon me, sir. There was a minute's time extra. So had to discuss a little bit about the discussion part.
Yeah,
so
but, can you just conclude your paper, because your overshadowed time in presentations? Can you
yes,
conclude?
sir. The conclusion would be like each syndromic clubfoot will behave differently, and the treatment aspect cannot be generalized. That is a take-home message. And our particular study was compared to Morcode, Joseph, and Van Bose, which included a number of patients of 16, 23, 10, and 89 patients. But our current study was about 129 patients. And the average casting which we took was 13.13. So as compared to other studies, we did a lot more casting, about twice as much of the others, but the number of patients studied were also more. So hence the average casting was more. So that's the bottom line, sir. Like basically syndromic clubfoot, the Ponseti method would be like the first line of treatment. We have to give a trial of Ponseti method for the correction of CTEV, and these syndromic clubfoots might require surgeries as well, sir.
What is your long-term follow-up?
Sir, for a period of 8 years, sir.
Okay. Now there are a couple of questions from the audience.
Yes, sir.
Yeah. One is number of casts required is quite high. Can you explain? That is the first question. I think Rujita has asked that.
Yes, sir. So since we are dealing with a syndromic child, so we are associated with the connective tissue disorders like Larsen syndrome. So whenever we deal with the connective tissue disorders, the number of casts in our particular institute went up to almost up to 13 casts, sir, which is realistic according to me, because syndromic clubfoots are very rare presentations, and it takes a lot of duration for correction.
Okay, now there are two more questions. How do you define relapse in these patients? That is question number 1. How do you define the relapse? And second question is, yeah.
So the relapse, what we ideally follow in our institution was percutaneous tenotomy. Once complete, the cavus is corrected and the abduction is corrected to about 60 to 70 degrees. If the equinus is difficult, we would take them to a percutaneous tenotomy and cast them for about 3 weeks. So after 3 weeks, we put them on an abduction brace, and in spite of the further follow-up of about 6 months or so, if the CTV is being recurrence, we consider that as a relapse, and we treat accordingly, sir.
And is the Pirani score relevant for syndromic fit?
Yes, sir. Yes, sir. It is relevant in our study. But yes, sir. So it's very uncertain, sir. And invariably, they might will have to undergo a surgical procedure
to correct the deformity, sir.
How many cases of particular arthrograposis they required some kind of surgical intervention in long-term follow-up?
Yes, sir. So arthrograposis, again, we took about 19 cases were taken up for posterior or medial soft tissue release, and about 5 cases were taken up for Ilizaro. And since it's a very the AMC child, since we have a rigid joint and there is limitation of motion, so they have been taken up. They have been taken up for surgery, sir.
Yeah, we have quite senior people. Dr. Benjamin Joseph sir is there. Dr. Kerr Graham is there. Benjamin sir, would you like to ask some question for the presenter?
No, I'm a silent spectator. Thank you very much.
Nice to see you, sir.
Yes.
Would you like to ask some question? He's spoken about the syndromic clubfoot paucity method.
I'm sorry, I've just joined the online discussion now, so I'm a little bit late and a little bit uninformed, so I'll not step in at this point. Thank you.
There is one last question from Thomas. Is adduction thumb clubfoot syndrome a subtype of AMC as described as syndrome?
Sir, adduction thumb clubfoot syndrome is an autosomal recessive connective tissue disorder, sir. So with congenital malformations, and there is a contracture of the thumb which is associated with the clubfoot, which involves the gene of CHST14 gene. So it is associated with, it's basically associated with AMC as well, sir.
Okay. Thank you, Dr. Ranjit. It was really a nice presentation. We are short of time, so we'll move to the next presenter, Dr. Pratik. Venkat, am I right? Because
Jaideep is not there.
Yeah, so Dr. Pratik is going to speak on post-septic hip dislocation sequelae in children managed with open reduction, a series of 11 children.
Septic hip dislocation sequelae in children managed with open reduction, a series of 11 children. Septic arthritis of hip has grave immediate effects as well as long-term unfavorable outcomes, which we most commonly discuss in terms of CHOI classification. Today we are talking about a specific subset of type 4A CHOI, where the capital femoral epiphysis is present and the hip is dislocated. Dislocation has not been discussed much as a separate entity, and no guidelines regarding management protocols have been established. Our aim was to assess the results of open reduction in such hips. We tried to find the functional and radiological outcome using Moon's criteria and modified Severin classification. We also tried to quantify the effect of surgical correction and relocation of these hips using acetabular index, center edge angle, Reamer's index, and neck shaft angle. We included 11 patients with a minimum follow-up of 18 months. Surgical interventions included 8 adductor tenotomy, 4 psoas tenotomy, transarticular K-wire fixation in 6 patients, pelvic osteotomies in 7 patients, which included 3 Salter, 2 Pemberton, and 2 Chiari. Osteochondroplasty was done in 1 patient. Proximal femoral varus osteotomy was done in 1 patient, and a second intervention in form of a VDRO was performed in 1 patient. As far as acetabular dysplasia measured in terms of acetabular index is concerned, the preoperatively significant dysplasia was present on affected side as compared to the normal side, indicating the effect of dislocation and infection. On intervened side, significant reduction occurred in the acetabular index in the follow-up, indicating the effect of surgery. The follow-up acetabular index on the affected side did not match to the normal side, indicating that despite surgical reduction, some residual dysplasia is present. And on the normal side, the change in the acetabular index was insignificant, indicating the normal decrease in AI with age. Average age was 20 months, and at the follow-up, average shortening was 2.3 centimeter. We found premature triradiate cartilage fusion in 3 patients, and Shenton line was broken in 6 patients. The difference in Reamer's index was significant. We also found significant coxa vara in the affected side as compared to the normal side at the final follow-up. Results in terms of modified Severin classification, we had 3 type 2 hips. 4 hips had some dysplasia, 2 hips had some subluxation, and 2 hips were articulating with a pseudoacetabulum. Functional outcome was excellent in 5, good in 4, fair in 1, and poor in 1 patient. This is a patient, 18-month-old child, right hip septic dislocation, post septic hip, open reduction, pelvic osteotomy was performed, and K-wire stabilization was done. We can see significant improvement in the acetabular index. Shenton line was broken, but the hip was reduced and stable with an excellent functional outcome. Another example, septic sequelae dislocation, left hip, pelvic osteotomy and open reduction was performed. At the final follow-up, capital femoral epiphysis was flattened, proximally migrated and articulated with a pseudoacetabulum. Moon functional grade was fair due as the patient was having uneasy squatting and cross-leg sitting. Thus, a significant acetabular dysplasia is seen on the affected side, which is a result of a dislocation of the hip or the infective acetabular affection. Surgical reduction restored acetabular dysplasia but could not match the other side. Persistent coxa vara was present despite varus osteotomy done only in 2 patients. Thus, pelvic side should be preferred rather than femoral varus. Despite altered radiological indices, broken Shenton line, and premature fusion of TRC, a stable and mobile hip with good clinical results is expected. Michel, in their study on 7 hips, performed pre-op traction, arthrography, and open reduction and were able to successfully reduce 6 out of 7 hips. Johri sir, in their study of 21 hips, attempted close reduction on 20 hips, succeeded in 7. They had flattened epiphysis in 10, dysplasia in 5, fusion of thyroid cartilage in 2, and redislocation in 1 patient. Thus, to conclude with, open reduction potentially alters the natural history of the disease and contributes to better hip mechanics and function. Thank you.
Viraj, you are not audible. Viraj, you have to unmute yourself.
Yeah, Dr. Pratik, thank you so much. It was really a nice presentation. I hope there must be quite a good number of questions from the senior colleagues who are here. Benjamin sir.
Let me.
Yeah,
there is a question from Thomas. Do you do pre-op MRI or an intra-op orthogram to plan the type of surgical procedure?
Yes, sir. Pre-operative MRI was done in most of the patients, but since ours is a government institute, many patients will not afford it. So I did not add those details into it. But in our study, we had 6 patients out of 11 who had a pre-operative MRI. And on the contrary, in 3 of those patients, the radiologist reported that this was a case of the DDH. So pre-operative MRI in these children with the dislocated hip post-septic sequelae could be a little confusing because many times you cannot differentiate from the developmental dysplasia of hip.
Okay. Dr. Kargam, would you like to ask something?
Sure. Is the practice of modified anomalous osteotomy considered in your practice to help stabilize and correct acetabular dysplasia, but also to get some trans-iliac lengthening? This was a favorite maneuver of my late great colleague Ian Turode.
No, sir, we don't perform that osteotomy.
I think you're.
I think Viraj, we are.
Yeah, we are running short of time. So, sir, Professor Kargam, you please your comment.
I simply wanted to say I think the emphasis on open reduction and achieving stability is the guiding principle for better hip development in the short term and a better place in the long term for an arthroplasty.
Okay.
Yes, sir. Thank you for that wonderful comment. And
Venkat, can you please conclude? I think we have finished the time, so please conclude.
Yeah, I thank all the presenters and the panelists for presenting the papers in the final session of free paper session of POSICON VirtualCon 2021. And with this, we move on to the next session. I hand over to the President and Secretary.
Right. Thank you very much, Viraj and Venkat. So now we move on to the final session of our POSICON, and this is going to be the symposium on the neuromuscular problem. We are really fortunate to have two great doyen of pediatric orthopedic, Professor Kirk Graham from Melbourne, Australia. He is going to speak on two topics which are very dear and near to his heart, and all throughout his career, he has focused on these two problems. The second speaker is, there is a change. Initially, Professor Durai Nayagam was going to speak, but because of the illness in the family, he has declined the invitation just before a week. And we requested our Benjamin Joseph, and he accepted our invitation. But the point which I would like to appreciate is that this lecture was not ready. So he's going to speak on the same topic on which Professor Nayagam was going to speak. So he prepared this talk in last 1 week. So I really appreciate that kind gesture of not changing the topic and to speak on the same topic. Without wasting much time, now I invite Professor Kirk Graham. Just 2 lines about him. He is considered to be one of the authority in cerebral palsy. He is at Royal Children's Hospital in Melbourne, and on various aspects of management, particularly the scientific aspects of management, he has played a significant role. So with this short introduction, over to you, Professor Kirk Graham. Thank you.
Well, thank you very much, Mr. President. I hope the IT will work, and we'll see how we go in just a moment. So, as you've heard, the topics that were given to me are things that I'm very interested in, but the actual titles were given by your esteemed president, and I've modified them slightly because we did try to make Victoria, the state in which I live and practice, crouch gait free, but we haven't entirely been successful. These are my acknowledgements, and there are no conflicts of interest relevant to this presentation. In terms of gait patterns in diplegia, we've been interested in this for some time, and we are keen on sagittal plane classifications. I'm going to talk about those and some of the pathomechanics of crouch gait, but you're surgeons, you're practical people, you want to help children, and therefore I'm going to spend some time talking about management and some clinical cases. This is our sagittal gait classification that we devised some years ago. 3 of these patterns in North America would be called flexed knee gait. That would be the 3 on the right side. But we differentiate between the yellow, which is jump gait, the green, which is apparent equinus, and then on the right, we define this as crouch gait when there is excessive dorsiflexion at the ankle, and that is frequently the result of some iatrogenic problems. The first person to graphically illustrate and address these problems was the late, great Mercer Rang. I had the opportunity of working with him at the Hospital for Sick Children in Toronto, and he could always reduce the most complicated problems to simple principles which were helpful to understanding. So he envisaged the child with diplegia having spring-loaded hip flexors, spring-loaded hamstrings, and a spring-loaded gastroc soleus. He said if you cut the springs at one level, you will produce crouch gait. If you're going to treat the child, you should lengthen the springs at 3 levels, and you should use an AFO. So I've been thinking about what holds the child with diplegia in the upright position, and I've been thinking a little bit about Isaac Newton and him wondering why the apple always fell to the ground, but it never disappeared into outer space. Some basic biomechanics are seen here by Dr. David Winter. This is the total body support moment, and it comes from moments at the hip, the knee, and the ankle, but the ankle or gastroc soleus contribution is by far the greatest. And when we consider some evolutionary biology, the primate that is walking as a quadruped has hip, knee, ankle, shoulder, elbow, and wrist generating moments. The orangutan that spends some time in bipedal gait has some bigger contribution from gastroc soleus, but it's only when the human becomes totally bipedal that the gastroc soleus becomes such a necessary muscle to maintain upright gait. And here is seen as a percentage. Here's the 100% of body weight, and in human bipedal gait, quite a bit of the gait cycle is spent above that line, which is energy efficient, whereas our nearest neighbors in the primates only cross over in early stance. So there's the contribution as you go through the evolutionary tree of the gastroc soleus, and it really is the crucial muscle in normal gait, and it's the crucial muscle in diplegic gait. These sagittal diagrams were inspired by your president, and I acknowledge his influence on me in using them. And as I thought about the sagittal support moments, the things that hold us and push us upwards, that would be the hip extensors, the quadriceps, and the gastroc soleus, well, really mostly soleus. And then the three things that pull us downwards would be contractures in the hip flexors, the hamstrings, and the gastroc soleus. And for the first time, only a few months ago, when pondering these things, I had something of a eureka moment when I realized that the muscle most needed to hold us upright is the one that we lengthen most frequently. And I think that's why any form of gastroc soleus surgery, we're always risking the development of a crouch gait. It is in fact mostly soleus, not so much gastroc soleus. That has led us to the concept of dose-based, very conservative gastroc soleus surgery, where if possible, we recess only gastrocnemius, sometimes a stripe on soleus, and very rarely anything in the Achilles tendon. All of that work is based on experimentation in human cadavers, where we did both anatomical studies, but more crucially biomechanical studies to show the amounts of lengthening and the various degrees of stiffness that was produced, or the reduction in stiffness when we lengthen these muscles. So here's our patient in the Gait laboratory, and when you see a young man with diplegia with this severity of crouch gait, but is able to move along quickly and using his forearm crutches, you can be absolutely sure this is iatrogenic. Yes, he's had TILs. When our Gait laboratory opened in 1994, in the 5 years prior to that, most surgery in Melbourne were TILs, some Baker procedures in zone 2, and mostly single level surgery. There was an immediate change in philosophy when we opened the Gait laboratory. We changed to zone 1 Strayer surgery, and that had a big effect on the amount of crouch gait that we were seeing. Each year, defined by the register that we have, we were able to see that in the early days after the lab opened, we had a full 25% of children in severe crouch gait when they left our institution, which was really unacceptable. That reduced rapidly and reached its nadir in 2000 and has remained low since, but we, stimulated by the request for this presentation, we will update these figures in the near future. My interpretation is that this is the natural history rate of crouch gait and diplegia, and unfortunately, this is iatrogenic. This is what we were doing in our efforts to help the children. Early TILs were producing crouch in teenagers. It's not all iatrogenic. This is much more recent. A delightful girl who's attended our Gait laboratory on 4 occasions at age 8, 9, 11, 12. And this is just a snapshot in the lab showing her progression of crouch gait. And I have given my colleagues a little bit of a hurry up saying that this is really not good enough. This is not the result of TILs. this is a result of delay because we could and should have done earlier surgery, as I've indicated here. Quite simple surgery in 2018 would have been enough. We could still have done something fairly simple in 2019. Now it's too late. She's had further delay with COVID and reduction in elective operating, and we are now going to be faced with much more complex surgery. So the most difficult level in diplegia is the knee, and here's 3 individuals. On the left, it's difficult. In the middle, it's very difficult. On the right, it's impossible. One of my bold and brave colleagues attempted to salvage this knee flexion contracture on the right, but it had severe complications and was not successful. As you know, there's a tradition in orthopedic surgery that we relied heavily on muscle tendon lengthening, particularly the hamstrings, with some stabilization of the foot, and that was only partially successful, as we and others have reported. More recently, more aggressive surgery for severe crouch gait has been widely used with distal femoral extension osteotomy, and in India, championed by Dr. Benjamin Joseph, femoral shortening, which has a very similar effect, patellar tendon shortening, fix the foot levers, and solid AFOs. It's a big surgical package. It's much more successful for the severe case. I just want to draw your attention to what now has, for us, taken over as the real mix that we rely on heavily, and we call this hybrid surgery. We use the semitendinosus transfer, introduced to us by Dr. Paulo Silber. We combine that with guided growth because if we act in time, the flexion deformity at the knee is typically only 5, 10, or 15 degrees, and that's a bit small for a femoral osteotomy, either shortening or extension. But this requires careful timing. The child obviously must be prepubertal. We must know the bone age and monitor carefully. So we think that hybrid techniques involve a process of knee surveillance and addressing the crouch gait comprehensively before the flexion deformity exceeds preferably 20 degrees, certainly a maximum of 30 degrees. The guided growth procedures that we have tended to use, and I'm sorry, this is slightly out of sequence, but this is our young man that we showed a moment ago after conventional salvage surgery. And he's now qualified in medicine. Prior to surgery, he was GMFCS2. Now he's GMFCS3. And of course, that allows his arms to be free for clinical examination for his work as a physician. He's a wonderful young man. He came back to work with us as a research assistant, and he's forging a career in Australia in medicine with a special place in his heart for those with physical disabilities. So hybrid techniques, the semitendinosus transfer as introduced to us by Dr. Silber, and then guided growth for the small remaining knee flexion contracture. And there are 2 options. We have relied very much on the use of 8 plates, but more recently we have introduced and adopted cannulated screws in the anterior 1/3 of the distal femoral physis. Takes a little bit of getting used to, a little bit more complicated to insert, but really effective and much better tolerated by our patients. They don't get the knee pain and bursitis that 8 plates can cause. And here's a young man with severe gait problems, severely contracted hamstrings, and here's his outcome after a combination of semi-T transfers and guided growth. The most critical dose in all of CP surgery is that of the gastroc soleus. This is a girl who was in our RCT of seminal surgery. I must say, when she pulled the card to be in the seminals group, I was not at all happy. She's already markedly overweight. She has a severe intellectual disability, and I did not think that she would do it all well. But with parental support, and despite gaining an enormous amount of weight, by preserving her soleus, in her middle teens, she is able to be brace-free. She's able to be free of assistive devices. And I put it to you that that is not anything more clever than preserving the soleus and recessing only the gastrocnemius. So I'll end by saying that SOS stands for Save Our Soleus. We can do primary prevention by identifying those children at risk. We should avoid TALs. We should do very careful dose-based surgery. There is secondary prevention by knee surveillance and guided growth around the knee. And I thank you for your kind attention and for this invitation.
Yes, we will take the questions at the end after all the three talks are over. So now I invite Professor Benjamin Joseph for his talk on Cabovirus.
I need...
yeah, I will do that unsharing.
Okay, yeah, all right. Can you see it, Dhiren?
Yes, perfect.
And you can hear me?
Yeah, well.
Okay. Right. So as you kindly mentioned, I am a substitute, but anyway, I'm going to talk on the cavus foot because I have some interest in this. By definition, the cavus foot is a high arch foot where the longitudinal arch fails to reduce even on weight bearing. That's a normal footprint. A high arch foot and a footprint of a cavus foot distinctly different from normal. And the types, there is a type called a congenital cavus, which is pes arcuatus. It's not associated with muscle imbalance. It does not progress, usually asymptomatic and distinctly uncommon, as you can see there. Far more common is neuromuscular pes cavus. It's associated with muscle imbalance. It tends to progress and is often symptomatic. Among the conditions that are associated with the cavus, first and foremost is the Charcot-Marie tooth, a variant of the hereditary sensorimotor neuropathy, spinal dysraphism of various types, spina bifida, poliomyelitis, cerebral palsy, and Friedreich's ataxia. Neuromuscular cavus, the deformity includes a longitudinal arch which is accentuated. There may be associated hindfoot deformities, which may be at the ankle, which might be equinus or calcaneus, at the subtalar joint, varus or valgus. There may be clawing of toes. And this is because of muscle imbalance at the ankle joint. If there is dorsiflexor weakness, you end up with an equinocavus, like that. If you have plantar flexor weakness, you end up with a calcaneocavus, such as that. That was in polio. At the subtalar joint, if there's everter weakness, you get a cavovarus, such as that. And if you're in inverter weakness, you get a calcaneovalgus. At the metatarsophalangeal and interphalangeal joints, if you have intrinsic weakness, you get clawing, as seen there. Often, deformities occur at multiple joints. It's more complex, such as equino, cavo, varus. How do you assess a child with cavus? Apart from doing a detailed examination of the affected limb, you need to examine the spine and do a very detailed neurological sensory system examination and a neurological examination in toto. We may need to do some tests, including EMG, nerve conduction velocity, and serum creatine kinase in some of these children. Coming to the foot itself, we need to identify all the components of the deformity, determine if the deformity is supple or rigid, and determine if some components of the deformity are compensatory, because if it is compensatory, you don't need to deal with that, deal with the primary cause which produces the compensatory deformity. And in particular, what we find is if the tibialis anterior is weak, it results in the drop of the first metatarsal and pronation of the forefoot. And that's one of the excellent illustrations which I am lucky to have got. And this is a diagrammatic representation. You're looking at the foot from behind. You can see that the first metatarsal is dropped. And in order to rest the sole on the ground, the hind foot inverts. So the hind foot varus in this instance is compensatory to enable a plantar tread with a pronated forefoot because of the first metatarsal drop, for which you do the Sherman-Coleman's block test to see if the hindfoot varus is rigid or supple. And here you see that the person is standing on a block. And here, the first tray is hanging over the medial end of the block. And there seems to be minimal correction, but nothing much. Diagrammatically, you can show this. The block test shows that the hindfoot varus is supple, because you can see that as the block is moved and the first tray hangs over the edge of the block, the varus gets corrected. On the other hand, in this instance, you can see that the varus doesn't, and so the varus is rigid. In the clinical assessment of the foot, probably the most important thing that one needs to do is muscle power testing and charting. And I can't re-emphasize this because this is extremely important. If you want to do any tendon transfer, you need to be able to test muscle power accurately. And I'm sure that Kerr will agree to this completely. Manual muscle testing is the only way to go. And then I would suggest that you plot and record the muscle power very carefully of all the muscles and tendons passing across the ankle and subtalar joints. You need to know the axis of the subtalar joint, the axis of the ankle joint, and the relationship of these tendons in relation to these axes. You then record the muscle power as shown here on each and every tendon, and this will enable us to plan our tendon transfer appropriately. Before we do that, we may do some radiological assessment. And it's important that if you do any form of radiological assessment in KBIS, it must be a weight-bearing lateral radiograph, because that's what's going to give you the information. You can measure the calcaneal pitch, Meary's angle. Normally, the first metatarsal long axis should run through the long axis of the talus. Calcaneal first metatarsal angle, normally that's about 150 degrees. And there are other measurements that you can do. You may also, if you have the facility for pedobarography, you can do static pedobarographs or have a dynamic one, which is quite exciting and colorful, but I'm not sure whether it gives any more additional information. Coming to treatment, there are basically two principles to follow. One is you need to correct the deformity and restore muscle balance, because you can correct deformity without restoring muscle balance. But that's not a wise thing to do, because you're bound to end up with a recurrence. So if you have a mild KBIS, how do you correct the deformity? Usually the plantar fascia is tight and you need to release the plantar fascia, and often a mild KBIS is corrected with that. If it's a moderate KBIS, you'll have to add to the plantar fascia release a mid-tarsal osteotomy. If the primary pathology is a first metatarsal drop due to a tibialis anterior weakness and the KBIS has become rigid, then you do a basal extension osteotomy of the first metatarsal. If the primary pathology is a calcaneus around which a KBIS is developed, you can do a calcaneal displacement osteotomy, a proximal displacement, along with a plantar fascia release. This is a useful procedure because you can combine the proximal displacement with a valgus or lateral displacement if there is an associated valgus deformity. In complex deformities, particularly in the adolescent stiff foot, you may often have to end up with a triple fusion. As I mentioned before, it's essential to restore muscle balance to prevent a recurrence. And I come back to this diagrams of the tendons passing across the ankle and subtalar joint. I emphasize that we must be conversant with the direction of the axes of these joints, because you need to remember that any tendon that runs anterior to the axis of the ankle joint is a dorsiflexor. Any tendon running behind the axis of the ankle is a plantar flexor. Similarly, any tendon lying to the medial side of the subtalar axis is an inverter, while those on the lateral side have to be everters. Once we understand that and we test the muscle power again and again to be quite sure what we're doing, we can proceed with the tendon transfer. In Charcot-Marie-Tooth disease, one of the relatively early muscle paralysis that you find is paralysis of the tibialis anterior and paralysis of the peroneus brevis. And the effect is the first metatarsal drops. And since the inverters are stronger than the everters, you can get a varus deformity, weakness of ankle dorsiflexion, and that can give us an equinus component as well. So how do we deal with this? The first transfer that we do is we transfer the peroneus longus to the peroneus brevis. Now that doesn't seem very intelligent because you're not going to increase the peroneus everter power remarkably. But the reason for doing that procedure is this. You've got to drop first metatarsal. And why does it drop? When you have the tibialis anterior and the peroneus longus acting on the first ray, that's the way it is. But when the tibialis anterior is paralyzed, you get a drop metatarsal because of unopposed activity of your peroneus longus. And if you take away the peroneus longus, the deforming force that produces the first metatarsal block is removed. And if you can do this rebalancing tendon transfer prior to a fixed deformity, you may then improve the cavus deformity. The next is you need to deal with the varus, and you need to do a tendon transfer for this. And here the best tendon to transfer is the tibialis posterior. And you can actually fine tune exactly where you want to place this tendon, attach the tendon. If you plot the power of each of these tendons, some of them may not be grade 5. I've just shown them as grade 5. Some might be grade 4. So accordingly, you can move the insertion of the new insertion of the tibialis posterior either further laterally or further medially or smack in the midline, depending on the muscle power of all the other muscles together. And I always recommend that when you're doing tendon transfers around foot and ankle, try drawing this grid and then planning your tendon transfer. You're less likely to go wrong. I'm going to stop at this point and then we invite questions if you have any. This is a very brief overview of cavus and cavovarus deformity. Thank you very much.
Yeah, thank you, Benjamin, for a wonderful explanation about the basics of cavovarus foot. We will come to the questions regarding the management in a short while. Now I invite Professor Carl Graham for his second talk about prevention of the contracture, which is really a very difficult question for us. So yes, Professor.
Well, thank you again. And I think I really feel that that was an outstanding presentation on cavus foot. Absolutely superb. Thank you so much, Benjamin. This is a talk that is somewhat of, it's a talk, but it's also an apology for some of the mistakes that I've made. And I'd like, before I finish up teaching and before I finish up clinical practice, to put right some of the errors that I promulgated during my time as a practicing surgeon. And I'd just like to acknowledge my dear colleagues seen here, and I love your graphics that you've used for POSI and for POSICON. And I particularly enjoy that picture top right because it's two of the great teachers of our generation. The late great Ian Turode is on the left of that photograph, and the man that we've just heard speaking is on the right. And that was a masterly exposition of the cavus foot. In 2007, a group of mostly pediatricians defined cerebral palsy, and this is now the international definition that it's widely accepted. The last 5 words in red are the 5 words that I prevailed upon them to add to the definition, because they had spent most of a week discussing spasticity and dystonia and epilepsy and feeding problems and all kinds of things. And I said, yes, but hips dislocate and scoliosis develops and contractures develop. And I found it extremely difficult to get them to pay any attention to musculoskeletal issues. And it still remains a very interesting issue to consider as to how something located in the brain could and would lead to such profound musculoskeletal problems. In early childhood, cerebral palsy all looks neurological, it all looks developmental, and we are considering all of those issues. But later in life, it looks very musculoskeletal. And here are some of the range of problems that may develop in different GMFCS levels. So why does it become from a neurological issue to a musculoskeletal disorder? Well, for many years, most of us have considered what we now call the positive features of the upper motor neuron syndrome. That is, that when you take away inhibition of the lower motor neuron, you get a constellation of features that we all feel when we examine the child: spasticity, hyperreflexia, clonus, co-contraction. They're all there. You can feel them. They're really tactile, and nothing feels quite like the child with cerebral palsy's muscles. Those features are just the hallmarks. But we do tend to forget that on the other side, because of loss of corticospinal tract innervation to muscle, to motor units in muscles, there's a whole host of negative features, which are weakness, loss of selective motor control, poor coordination, and sensory deficits. Many years ago, inspired by Mercer Rang, I returned to my home of Belfast with his mouse model, the hereditary spastic mouse. I was very interested in those days as to what the role of botulinum toxin might be. Here are some of the mice, an affected and unaffected littermate. And on the right are the dissections of the gastrocnemius soleus. The foot is flat on the ruler. The gastrocnemius soleus is seen, and that's the stump of the femur. And perhaps you can appreciate that on the right, that's a spastic mouse, and on the left, that's an unaffected mouse. And the gastrocnemius soleus is smaller, and the tendon is shorter, and the stump of the femur is being pulled into flexion. Well, we did an experiment that was then published showing that if we injected botulinum toxin when the mice were very young, approximately 5 or 6 days old, we could prevent the progression and development of contracture. And this seemed to be very exciting for us. It seemed to be, they opened the door to using botulinum toxin for children with CP. However, the methodology was very simplistic. The mice did not have cerebral palsy. It's never been replicated in another animal model, and unfortunately, it's not been replicated in children with cerebral palsy. So, after much consideration of experimental work and all kinds of other areas, we've really reached a very strong conclusion in recent years that contractures are not caused by spasticity, and therefore treating spasticity with whatever you choose, botulinum toxin, rhizotomy, baclofen, it doesn't prevent contractures. Now, we moved to starting clinical work in children after the mice work, and we initially had some reasonable grounds. I'm sorry, my movies don't seem to be queuing the way they should be, but here's a little girl aged 22 months. She's got diplegia. Mom's holding her hands. She cannot walk independently. She has bilateral calf injections. The spastic equinus is treated, and later she starts to walk independently. We thought that was the result of the botulinum toxin. Now we know that she was GMFCS2. She was always going to walk independently. And we are much less concerned about the need to treat spasticity and the benefits of treating spasticity. Probably one of the main issues is that these baby mice with the hereditary gene for spasticity, they reach skeletal maturity after 28 days. And of course, the child with cerebral palsy will grow for 14 to 16 years or longer, because many have delayed bone age. So this was a case of the mouse study failing the human test. What seemed to work in a mouse didn't work nearly as well in a child with cerebral palsy. So in cerebral palsy, everything works some of the time, nothing works all of the time, and most things don't work as well as we think they do. And we can still end up with some really quite staggering cases of deformity, such as here. This is a boy in his middle teens in Australia from another state, almost completely untreated, and that was largely the choice of his parents. And you can see the severity of the contractures, the scoliosis, the hip dislocation, joint contractures. In fact, when the family moved to our state, the first request was, would we consider amputations of his legs, because it would make his nursing care more simpler and easier. So in cerebral palsy, we need interventions that are this strong, because the deforming forces are very strong, but most interventions are only about this strong and are not up to what we really need them to do. Here's a girl who was in my practice 20 years ago, and I was trying to keep her hips in joint. even in those days, we didn't have GMFCS. I didn't know that she was GMFCS 5. Mum was holding her up in the upright position. We thought maybe keeping her hips in joint and treating her contractures, perhaps one day she would stand, maybe she would even walk. Her cerebral palsy was associated with severe congenital cardiac disease. I never got on top of her hips, and when she developed scoliosis, my colleagues said, no thanks, she's too great of a risk. And this is how her spine looked when she was in her early 20s, and shortly after this, she died from respiratory failure associated with severe scoliosis. The last 5 to 10 years of her life was miserable with pain. She was bedridden. Her mother moved her and changed her position 3 times minimum every night. And so the burden of managing a child with severe deformities is incredibly severe. In cerebral palsy, muscles are weak. That's why it's called cerebral palsy. They're small, they have a short belly, they have a long tendon, but the overall length of the muscle tendon unit is long, and it doesn't match the neighboring bone. So the bone has a certain length, and the muscle tendon unit has a certain length, and they don't match. And this is illustrated both in a cross-section here of what diagrammatically what the muscle looks like in typical development on the left, and in cerebral palsy on the right. Elongated sarcomeres on the right, fewer cells, a large reduction in satellite cells, and a large increase in collagen. Botox is not the answers to contractures, unfortunately. And it's not even a spasticity treatment. We now know that it actually simply causes chemical denervation of the muscle, a chemodenervation. It causes muscle atrophy. It does reduce spasticity, but that is secondary to the denervation. And then worst of all, it has changes in the muscle, which include fibrosis, fatty infiltration, which to the best of our knowledge, the recovery is slow and incomplete. Neither in animal models nor in children with cerebral palsy do we have convincing evidence that the muscle recovers fully from a single injection of botulinum toxin, contrary to what we used to think, contrary to what we used to teach. The next few slides are from my colleague, Dr. Jason Howard. He was then at Sidra Medical Center in Qatar, and more recently has joined the unit in the DuPont Institute in Wilmington, Delaware. And he's an orthopedic surgeon, but with a big interest in muscle, and he will be a wonderful addition to your teaching faculty in POSI in years to come. So this is a rabbit study, and here we see what the muscle looks like at baseline, and these are the changes at 1 month, 3 months, and 6 months after a single injection. And most of this white is fatty infiltration, and the muscle has not recovered, and 6 months is a very long time in rabbit years. And there's the damage done to the muscle by injection of toxin. So rather than relieve contracture, it is almost certainly contributing to contracture. One of the issues is probably increased connective tissue, probably type 1 collagen. And here's hamstring contractures, control hamstring histology, cerebral palsy hamstring ecology, and here's stains for type 1 collagen. Now, Dr. Howard has proposed that we stop injecting with botulinum toxin, which I agree with, and he suggested that we should try and target this increased connective tissue with injections of collagenase. Now, having been through the introduction of one ineffective injection therapy, I'm willing to be open-minded. I'm willing to try this, but I'm skeptical that it will be the answer that we're all looking for. So this is the proposed trial in the rabbit model, injection of collagenase and various mechanical, biomechanical, and histological studies. But I return to the need and the wonderful tool that we as orthopedic surgeons have, muscle tendon surgery. And this is a tibialis posterior muscle. It's a cadaver muscle tendon unit excised from the cadaver and put in an instron unit. I've made a little intramuscular tenotomy towards the distal end of the muscle. And then as you apply a traction force, you can get lengthening and continuity, because once you have divided the excessive connective tissue, the muscle itself becomes much more elastic. And you can continue this according to where the force that you apply and the position in which you put the tenotomy. And this is probably a bit overdone and almost about to rupture. But it shows the scope for lengthening of a muscle tendon unit to correct fixed contractures in cerebral palsy. This is the experimental setup with tibialis posterior, and what we were doing in this particular set of studies was altering the position of the intramuscular tenotomy to see if we could alter the lengthening characteristics, and that in fact was shown to be the case. And I think it leads us to know that our surgical techniques can be refined, they can be targeted, they can be just like Benjamin showed in the last lecture, by knowing the muscles contributing to deformity, those that are strong, those that are weak, those that are paralyzed, those that are contracted, those that are not. We can be much more sophisticated in our approach to these problems. And here's just one of the lengthening curves of a high and a low tenotomy in the tibialis posterior. So I return to the needs of our children with cerebral palsy. This is a wonderful boy, a sagittal view. He came to our Gait laboratory. He had multi-level surgery at age 10. He had a semitendinosus transfer for his flexed knee deformity. He had gastrocnemius recession. We fixed some of the bony deformities. At B, this is him at 2 years, and pretty much at 2 years, you can almost predict what the long-term outcome will be. And you can see as the hirsutism increases as he goes through puberty, this is now 10-year follow-up, and he has remained with a fully extending knee, a plantigrade foot. He's GMFCS3, so he still uses crutches, but he's brace-free. He's a community ambulator, and he's now finished his studies and he's working in the workforce. Sometimes contractures get away from us. This is not cerebral palsy, but this is Wilson's disease, intractable dystonia. This girl came from another state after 18 months in this condition. She had full thickness sores in her elbow creases. She had full thickness sores in her hamstring and her popliteal fossa. And with simple soft tissue surgery, she is first of all extended, and then with rehabilitation, here she is with some ambulatory ability restored. So I'm looking forward to all kinds of things that we may be able to do with injectables. I've been grossly disappointed with my experience in botulinum toxin. We will certainly look at novel therapies with collagenase, and especially the potential for increasing satellite cell populations in young children. But we are going to be doing dose-based, careful muscle tendon surgery for many years to come. And thank you for your kind attention.
Yes, thank you very much, Professor Graham. Now, I will start with the first question, and which is a very basic question. For years together, in the management of cerebral palsy, we were focusing on stretching. That stretching could be by physiotherapy, by nighttime brace, or by stretching cast. So what are your views about this changing scenario? Like, say, if we take away this, then probably there is hardly anything left for the non-operative treatment for these children except strengthening exercise. So how do you, and the Botox already you are now saying that that's not a good treatment. It creates more harm than the good. So with that, how do you treat these children initially?
Well, I would say two things, but it's an excellent question, and we're asked it all the time. One of our very first clinical studies in younger children with spastic equinus was to compare stretching casts and botulinum toxin. And that study was well done. It was randomized. The outcome measures were done with gait analysis. And essentially, there was virtually no difference between the benefits of a stretching cast and an injection of toxin. Parents preferred the injection because especially in summer in Australia. It's much better to be without a cast. But essentially, the effects are very similar in magnitude and very similar in duration. But probably the stretching cast is safer than botulinum toxin. So we have historically interventions which are effective, and it doesn't mean that we've got nothing left. In addition, I keep trying to remind all of my colleagues, and especially the junior staff coming through, that in the long term, in diplegia, it's not Aquinas that's the problem, it's crouch. So we don't have to correct every last degree of Aquinas when children are 2, 3, 4 years old. It doesn't harm them excessively. They can progress, they can learn to walk, they can improve their motor skills. We should do a little with physiotherapy, with stretching casts, sometimes the use of orthotics, but we should keep our surgery until later, and we should be very conservative, especially in those first 6 years.
Thank you. Over to you, Jayant, for the further discussion and questions.
Thank you, Dhiren. We have quite a few questions from our delegates, both for Professor Graham and Professor Joseph. So I'll start with Professor Graham. Dr. Rujita Mehta from Mumbai was asking whether you would, instead of Botox, inject absolute alcohol or phenol, because they're much more inexpensive compared to Botox.
It's an excellent question, and it's lovely to hear and see you again, Jay. We've continued using phenol throughout the Botox era, but we've only used it in 2 nerves, and that would be the obturator nerve for intractable adductor spasticity, where the muscle's effects are never going to be beneficial. They're always going to be harmful in terms of hygiene, nursing, diaper changing, or hip displacement. So when we want to do and trial a neurectomy which is not going to recover fully, we're perfectly happy to use alcohol or phenol. So 5% phenol in our center is cheap. It's a fraction of the cost of Botox. We've always used that over the past 25 years. In the upper limb, it's wonderfully effective for excessive spastic flexion posturing at the elbow when we inject the musculocutaneous nerve. But those are the only 2 that we do, because if we use it on mixed nerves, if we use it below the knee, on the posterior tibial nerves, if we use it in the main sciatic nerve, we inevitably get sensory dysesthesias, and that undoes much, if not all, of the good of the reduction in tone. So I think its use in mixed nerves is very limited, but it comes back to this. Once I really focused on the idea that botulinum toxin is causing denervation, we know that our children have an upper motor neuron lesion. Why would I want to add a lower motor neuron lesion? So in our highly functional kids, GMFCS 1 and 2, we don't want to use phenol, alcohol, or botulinum toxin.
The second question, thank you. The second question is from Dr. Somesh Virmani. And I also have an interest in the same question. Would you not advise even 1 dose of Botox at the right age that is well timed, perhaps around 4 to 4.5 years, which helps you to buy valuable time in a child with uncontrolled spasticity, and just buy an extra couple of years so that you can push them onto the surgical window, as it were, the earliest surgical window? What are your thoughts on very limited and careful use of Botox?
Thank you. Excellent question. So we wrote an article in Pediatric Drugs last year, 2019, 2 years ago now, and it was heavily criticized by the rehabilitation doctors, and we were, in truth, we did overstate our objections, but having felt somewhat responsible for the overuse of botulinum toxin, I really did want to make some effort to bring it back to a more sensible use. So we're going to try And over the course of the next year with my new colleague, Dr. Eric Rutz, we're going to try and rewrite some protocols, because in our center, botulinum toxin was taken out of the hands of the orthopedic surgeons. It has been used by the pediatric rehabilitation doctors. And I can show you patient after patient who receives injections 2 and 3 times a year from the age of 2, sometimes until the age of 20, without a single orthopedic consultation, without a single x-ray of their foot to show the progressive cavo varus, which is now fixed with arthritic change and is too late for simple surgery. So this is typical human behavior. We don't have Botox, then we have Botox, then we grossly overuse it, and we've got to come back to some more sensible middle ground. I think there probably is a small middle ground, and I would define it as the least amount in the fewest muscles, as infrequently as possible, and for no more than 2 or 3 years, probably 2 to 4 years or 5 years, and then stop.
Perfect. Thank you so much. That was very helpful. We have a lot more questions for you, but in the interest of time, I'll clear a couple of questions for Dr. Joseph, and then we will come back to CP so that we're maintaining interest in both topics.
Sure.
From Dr. Rajiv Gandhi to Professor Benjamin Joseph, how do you choose between a tibialis anterior or a tibialis posterior transfer for a cavovarus foot, for a dynamic cavovarus foot deformity?
I use the example of Charcot-Marie tooth disease, where almost invariably the tibialis anterior is paralyzed. And in such a situation, you transfer the tibialis posterior. Again, if you draw the grid which I showed, you can easily decide which tendon you need to transfer. Suppose the tibialis posterior is weaker than the tibialis anterior, yes, certainly the tibant is what you transfer. But the example I showed was a paralyzed tibant with a paralyzed peroneus brevis, and in that situation, the transfer. So I used just one example for want of time. But yes, we can transfer tibant if the tib post is stronger. Oh, sorry, if the tib post is weaker. Yeah.
So I have one more question. We now have genetic diagnosis available for Charcot-Marie tooth and the hereditary motor sensing neuropathies, but they are expensive. I would like your guidance on whether it is worthwhile for us to confirm the diet, to do a genetic test, or has it had any bearing on your clinical decision making? Has it improved your overall treatment?
I mean, I would like to know the diagnosis to be precise. However, if you make a clinical diagnosis and and you are convinced that there is some progression, you can certainly go ahead and do your tendon transfers, because the natural history of CMT is that it does progress, and that some of your operations, the deformities will recur, but that can be delayed to some extent, and the end result might ultimately still be a triple fusion that's there. So I don't think that we must be completely, stuck to doing the genetic testing. If we can, well and good. Otherwise, go on clinical grounds. If you have a suspicion of progression, it's our duty to inform the parents that deformities may recur. But I think you give function for some time for the child.
And one more question is, when is the earliest you would operate on a cavovarus foot? Because sometimes we see a very early deformities in 6, 7, 8-year-olds where just the plantar fascia is tight. Is it worthwhile doing early soft tissue releases, or would you wait until they are much older, until they decompensate before, etc.?
I prefer to do them early. That's my preference. But having said that, I've seen recurrences also. If I may be permitted, with your permission, if I make a comment about one of the questions that was asked to Kerr about stretching, we all know that any type of scar, of whatever reason, maybe a burn scar or a scar after a snake bite or whatever you got over your flexion crease, if gently stretched, it does help. So collagen does respond to stretch. But if you are very rough and violent, it's counterproductive. So stretching certainly will have a useful effect for the collagen. So I think that passive stretching should continue as part of our armamentarium for cerebral palsy.
Thank you so much, sir. So we have a few more questions for Professor Kurgram. And there's a lot of interest about the role of semi-T transfers. And in India, we have stopped lengthening biceps by and large, but we are also doing a lot of medial hamstring lengthenings. And I think many of the questions are directed to what you think is the role of isolated semi-T transfer, because that seems to be the flavor of the month these days. If you could just compare and contrast a medial hamstring lengthening with a semi-T transfer.
Thank you. Can I just check that I've stopped screen sharing? Are you seeing everyone?
Yes, we are able to see the screens now.
Okay.
That's done.
I have the great opportunity of working with a group of colleagues from around the world, some from North America, some from Europe, and 2 of us in Australia. And it's led by Jim McCarthy from Cincinnati Children's. He calls it Mission Impossible. And what we're trying to do is come up with agreed indications and outcome measures for the different procedures in children with cerebral palsy. One paper is being published on hamstrings, one on gastrocsoleus lengthening, but we're redoing the hamstrings and looking at the semitendinosus transfer as much as we can. So I would just point to the fact that that paper will probably be submitted, maybe published by the end of this year, and many of these issues will be dealt with in a systematic way, and it will be a Delphi process of 15 surgeons, and I hope that will be useful. My personal feeling is that I am incredibly impressed with the benefits of the semi-T transfer, but my wonderful colleague who has now moved to North America, Dr. Paulo Selber, he convinced me of the value, but he was such an advocate for his patients. He did not have equipoise, and he would not accept a randomized trial. That was my goal from I first saw the semi-T transfer. Let's randomize, let's sort this out, because it's a significant departure, and we really need to know. And we have the tools with a Gait lab to measure it. But he resisted that, so our level of evidence is rather weak. But just anecdotally, I feel that it has 3 advantages. When you turn the semi-T back up and pointed northwards towards the hip, it can never reform, and it can never ever flex the knee again. It's out of the equation. And maybe that's what a rectus transfer does. Number 2, I do think it augments hip extension power. And I've just been reviewing the literature, and the independent Portland group, who are not all that pro semi-T transfer, they have reported that hip extensor power increases. And that's the issue of trying to preserve and protect against increased anterior pelvic tilt. In general, the answer to the biceps question is that in general, we do not lengthen biceps ever at the index surgery for several reasons. We think it's too much. We think it will increase the risk of a nerve stretch injury because nothing is left to protect the neurovascular bundle. And we think it's generally too much. However, as our children get older, we can see a relapse, and many of our children do get recurrent contracture as they go through the pubertal growth spurt. We will then, if the pelvis is in a fairly good position and we're not concerned, we will then do sometimes an isolated lengthening of biceps and guided growth for the remaining small knee flexion contracture. But that would be a second stage surgery.
So I think we have time for one more question. And this is been asked by several people, including Kapil Gangwal from Jaipur. When should one add a patellar tendon advancement to the standard hamstring surgery, whether doing hamstring transfer or growth modulation?
If I've understood correctly, 2 things. I am so impressed with my colleagues in Gillette Children's Hospital for their work on patellar tendon advancement. They've stuck with one procedure. They're very honest in their reporting, and we now know that's very solid data. However, Dr. Eric Ratz, my new colleague, and Paolo Selber both preferred patellar tendon shortening, and they've both convinced me that patellar tendon shortening with the new synthetic materials is simpler and more effective with fewer complications. So I think it's patellar tendon shortening for most of us rather than advancement. Now that we have very effective hybrid surgery, a combination of semi-T transfer and guided growth, we will typically do that. And once the knee comes out to full extension, then if there is a persisting extensor lag, patellar tendon shortening is the final part to augment that knee function.
Jayant, if I may interrupt at this point, I'd like to mention, Kerr, I'm not sure whether you're aware that in our protocol for crouch gait in the adolescent, we always add a semi-T transfer.
Yes.
And we always do a patellar tendon shortening without any fancy synthetic material or putting wires through the patella. And we've just looked at our 5-year follow-up and the results are remarkable. They're maintained.
I think your protocol, as I learned and followed and saw what you were doing, I see that there is an 80 to 90% overlap in what we're doing in all of the essentials. There is so little difference. I think that the issue of whether you go, Paolo Selber, when we started in Melbourne, used a Steinman pin through the patella to neutralize the pull on the patellar tendon and a long leg cast. You can definitely achieve outstanding results with such a technique. It's just a little more restrictive, and I think that the synthetic materials are not so expensive, and you can certainly get 2 or 3 loops from one single length of fiber tape, and it does make it a little earlier and perhaps a little easier if the patient is a teenager who wants his independence a little faster. Paolo Selber taught me, and he was absolutely right, that if you regain the extension, you don't need to worry about holding the knee in extension and a cast. You will get your flexion back always. It's getting the extension that's the critical issue. So you're absolutely right.
Yes, thank you very much. We are running late, so I will end the session. But Professor Kerr Graham, I would definitely request that let's have one full 2 hours webinar on this, because a lot of our POSI members have questions and they would really like to understand your concept of thinking. So definitely in our next 1 or 2 months, we will request again to join us for one webinar. So with that, I thank both of you for wonderful explanation about the basics of management. And with that, now we go to the next session that is about the valedictory function. It's going to be only 5 minutes, so please bear with us.
Thank you so much.
Thank you.
Yeah.
Thank you very much.
So yes, now we come to the last part of the session, and I would like to thank all of you for a wonderful support. So before I forget, I would like to thank the delegates. We were really happy to say that we have a 229 registration and 10 international faculty. So in this difficult situation also, we are able to carry out a wonderful POSICON, and that has a lot of benefits also. No doubt we are missing the social part of POSICON. I would also like to thank faculty who has really taken a lot of time for making the presentation, all the moderators of the case discussion session for finding out the difficult and challenging cases, and panelists for sharing their views in the discussion. I would also like to thank scientific committee. We had 113 abstracts, and in short time, they had to analyze all these papers. And from that, they selected the 26 papers which were selected for the podium presentation. And we had 55 e-posters also. So I thank my committee for taking a lot of efforts for deciding the papers. Also, I should like to thank the paper and posters presenter, because it's the most important part of the POSI. And we were initially skeptical whether we would have a good response or not. But we also had a wonderful response from the paper and posters presenters. So like every year we had more than 100 requests, and from that we selected, and 26 paper presenters and 48 e-posters presenters, they presented their work. About the judges, we had international judges, Professor Fritz Apti, Professor K. Sriram, Sanjeev Sabarwal, and Sanjeev Madan from UK. They participated as judges. Viraj Singade and Venkatadas, they were also judges for the e-posters session. All of them have really worked hard to scrutinize the paper and to select the best paper. It was really difficult for them to select the best paper. I'm going to share the results of posters in a while. Regarding the certificates, everyone will get certificate as a delegate, as a faculty, as a paper presenters, as e-posters presenters. So please wait, in a week's time, you will receive e-certificates by an email. I would also like to thank OrthoTV for making this scientific program technically sound and without major hitches. So once again, Dr. Ashok Shyam, Dr. Neeraj Bidlani, and Mr. Rajesh Menon for looking out the technical part. I would also like to thank Uma Surgical for their support to the scientific session. We know that it was very difficult for every industrial company to support the scientific event in this difficult time, but they were kind enough to support this event. I would also like to thank all the members of executive committee. It's only because of their lot of efforts we are able to give such a good program to all of you. So every member of executive committee has played one or the other role in this conference. So I would also like to thank to them also. So now we come to the most sought for part, and for that I request Dr. Viraj and Dr. Venkat, because they were playing a very important role in the scientific part, particularly for the papers and posters. So I request them to declare the results. Over to you, Viraj.
Thank you, sir. Viraj?
Please announce the best posters award first.
Yeah, so first I'll tell the best poster award. We had about 55 papers submitted for the best poster, and out of which 11 were selected for presentation. And of this, we had selected 2 papers. The best poster award is shared by Dr. Roshan Banjara, who presented on surgical phocomelia as a method of reconstruction after resection of sarcoma of humerus in the children from All India Institute of Medical Sciences. And the second paper was by Dr. Ganesh Singh Dharmshaktu. He had a good case series of fracture dislocation of shoulder in pediatric population. So both of them are sharing the first prize for the best poster award. Congratulations to the winners. And I request Dr. Dhiren to announce about how will they get the certificates and the prize money.
Yes, both the awardee will get their certificate by email. That will be a soft copy, but definitely during next conference, we will give them the physical certificate also. And their prize money will be transferred to their bank account tomorrow. So what we decided that we are not going to divide the prize, but we are going to give each of them 300 rupees, 3,000 rupees prize. So they will receive tomorrow by bank transfer. Thank you.
Thank you, sir.
Yeah. Now, for the best paper session, for the best paper award. So the third prize goes to Dr. Deepika Pinto. She has paper on demographic and practice variability amongst Indian centers in a multi-center prospective observation study on developmental dysplasia of hip. Congratulations, Dr. Deepika Pinto. I would invite Dr. Dhiren Ganjwala to please felicitate Dr. Deepika and announce the prize money.
Yeah, so again, Deepika will get the certificate and the prize money by bank transfer, and we will also give the physical copy during the next conference.
Yeah, once again, congratulations. Now the second prize for the best paper session goes to Dr. Bhushan Sagde. Spoken on observational gait analysis in children with cerebral palsy using the Edinburgh Visual Gait Score and smartphone-based slow motion video technology. It was really a wonderful paper and very innovative idea. I must congratulate. And again, I would invite Dr. Dhiren Ganchwala to please felicitate Dr. Bhushan Sagde.
Yeah, congratulations, Dr. Bhushan. Your paper was really a very innovative idea. And what Dr. Benjamin is always telling us that we in India needs something economical and innovative ideas. So your paper was definitely in that direction. So once again, congratulations, Bhushan.
Yeah. Now the first prize for the best paper award goes to Dr. Maulin Shah from Ahmedabad. He has a paper on clinical surveillance of the infantile shoulder dislocation, residual brachial plexus birth palsy, and its correlation with ultrasound diagnosis. Congratulations, Maulin. Maulin is, I think, very persistent in last 4 or 5 POSICON I'm seeing. He is trying to present some of the other paper on brachial plexus palsy. Congratulations, Maulin. And I will invite again Dr. Dhiren Ganchwala, present, as well as our secretary, Dr. Sandeep Patwardhan, to felicitate all the winners and announce the prize.
Yeah, Sandeep, please, your comments about the winner, and then we end the scientific program of this conference. Over to you, Sandeep.
So, congratulations, Maulin, for winning the Best Paper Award again. And I think, like Lata Mangeshkar, now you must stop accepting Best Paper Awards because I think he's been getting this award for the last 4 years consistently. And he has done some exemplary work in brachial plexus palsy. So, congratulations. And as Dhiren Bhai said, you will get the money transferred to your bank account. And thank you to everybody who has really participated in POSICON virtually as a delegate, as a faculty, as a moderator, as a panelist, as a backstage actor, social support, moral support, psychological support, and Ashok Sham, Neeraj for excellent AV and seamless and flawless and within time. So it's always a team effort. And thank you, Dhiren Bhai. Being a president, he could have sat back in the chair and just ordered people around. But Dhiren Bhai was the organizing secretary of Virtual POSICON 2021. So I think he deserves the biggest round of applause. Congratulations to Dhiren Bhai. He's looked after every small detail and taken the POSICON to a really different level. So it's over to Rajiv Negandhi again now. At least next year, we hope to meet in Goa, have some social interaction, a couple of beers on the beach, in addition to great academics. Thank you very much. And let's sign out from POSICON 2021. Thank you.
Thank you.
Thank you, everybody.
Yeah, thank you.